I believe I see 8. Is that
That's
all
what I
right?
see.
We are
Okay.
ready.
All right. Thanks so much all for your patience. And I want to say good morning to you all. Hopefully you're staying cool after, at least in our area, a day like yesterday. So one that oftentimes we say we're not used to, but more and more we are. So I want to just thanks all for being here today to DCYF Oversight Board meeting. And as you may have seen on the agenda, we have a very full agenda today with a variety of topics that I think are really critical and will provide a lot of information, but also opportunity, I think, for discussion. And those things include access to info about and updates around access to substance use disorder treatment from the Department of Children, Youth, and Families. An update about the statute change work that is being considered, and that'll be presented by Lisha. We'll also have an overview of the 2025 Office of Family and Children Ombuds report on child fatalities and near fatalities in Washington State from OVCO and from Patrick Dowd, and also a response to some of the data in the presentation from DCYF. They'll be sharing information as well. So we fully expect, and I hope you agree, that we're going to have a meeting packed full of really good information. But as I said, also time for discussion on these very important and critical topics. And with that, I want to pass things over before we get started with the meat of the meeting, if you will, to Lisha to do both roll call and approval of the minutes from our May 15th meeting.
Great.
Thanks.
Thank you.
Good morning, Lisha.
Good morning, Senator Wilson, and good morning, everyone. So we're going to do board member roll call. Please unmute yourself and let me know that you're present when I call your name. We'll start with Anna Armstrong. Representative Steve Berquist. Katie Byron.
Present.
Good morning. I know that Bobby Bridge is absent. Senator Leonard Christian. Representative Tom Dent.
Rep Dent's here.
Good morning. Dr. Ben DeHaan.
Present.
Good morning. Dr. Marion Harris.
Here.
Hello. Pamela Javier. Danielle Johnson. Ruth Kagi.
Present.
Good morning. Dr. Diane Levy.
Present.
Hello. Lois Martin. Mary Spruti Garlant. And I think she currently is waiting to be promoted to a panelist. If that's still the case, if you could help with that, Nicholas, that would be great. Thank you. And then April Messenger put in the chat that she is currently driving, but I believe is present. Please be safe, April. And finally, Senator Claire Wilson.
Present.
Wonderful.
I'm here now. I'm in the main room now.
Oh, wonderful. Thank you. I am working from one screen today, so thank you for chiming in, Mary. I appreciate it. So I believe we are at quorum. Nicholas, could you please confirm that? So quorum would be 8.
I can count our screen, and I do believe we're at 8. And I don't know whether Nicholas might be having some connection problems, but we are in fact 8 plus.
Great, thank you. My one monitor cannot hold everyone, so I appreciate that. So next, I'd like to request that the board consider approval of the May 15, 2025 meeting minutes. Does anyone have any edits or feedback to the minutes? Okay, is there a motion to approve these minutes?
I move to approve the minutes.
Thanks, Katie. Is there a motion to second?
Second.
Thank you. All in favor say aye.
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 All opposed say nay. Any abstentions? Okay, with that, the minutes are approved. Back to you, Senator Wilson.
Thanks so much. And I have the honor, and thank you for getting all those things done. And I have the honor and the pleasure of inviting and introducing Dr. Sarah Veal back to present. And she is the director of DCYF's Office of Innovation, Alignment, and Accountability, and has been with us before. And today she and her colleagues are going to be talking about access to substance use disorder treatment. And Sarah, I see you. Good morning. And I want to pass it over to you and to those that you're bringing with you. Please feel free to unmute yourself, share your screen, and hopefully you can all do some introductions so we know who we are speaking with. And I will pass it over.
Wonderful. Thank you so much, Senator Wilson. It's a pleasure to be here this morning. We had a 9:15 start, so I think a few of our folks are joining as is, so I might get us started and then step back and do some introductions so we have a chance to meet everyone when they're here. Thank you. As a reminder, we've been trying I'll introduce myself. I can do that part. Sarah Veal, I'm the director of the Office of Innovation, Alignment, and Accountability at DCYF. We've been trying this past year to work with Oversight Board to identify areas that are critical for you all for consideration, things that you are really interested in that we want to be able to bring both data, research, and then the applied perspective to. So as you recall, we came and talked about education access a few months ago and JR and child welfare. In this presentation, we're going to talk about opioid use disorder, as well as opioid treatment and prevention access. These are huge topics, right? So last time we rushed really quickly through it. We added 15 minutes to talk about this topic, which is still a huge topic. So the goal really is to give you an idea of the work that's happening in DCYF, some ideas of the challenges that we're facing that you all may be able to support the agency with, and then connect you to some folks who have the expertise in our agency. So if and when you have follow-up questions, you have the opportunity to reach out to myself or my colleagues who will be presenting today. Pulling up my slide deck, excuse me. All right, so I will give a couple more minutes and I'll come back to our introductions. I'll give some context instead. Really just want to talk broadly about why we're here today. As I said, the bigger picture of why we're coming to this group is to share key information. I don't think I need to spend a whole lot of time explaining to you all why opioid use disorder is such a critical issue for DCYF. It's a critical issue for Washington State. The figure that we show here is looking at the Washington State population as a total, but these are deaths across Washington State and the changes over the past 2 decades. So over the past 20 years, we've seen a significant quadrupling, in fact, of deaths related to opioid use. We also see that some of the highest rates are in rural counties. And so I want to just call out this need for service as well as prevention and treatment in rural counties as well. So as you all know, opioid use disorder is having a major impact on our population in Washington State, but obviously also nationally as well. And we want to talk about it in this context, but also think about it more broadly, right? As our culture changes and shifts, substances that are being misused change and shift as well too. We want to be thoughtful about not solving specifically for opioid use disorder, but rather thinking more broadly about ensuring that we have access to services for prevention, education, treatment, recovery for the continuum of substance use disorder. So in our desire to try to frame this in a meaningful way in a short period of time, we're going to focus primarily on opioids, but I'm asking you all to think more broadly about this in terms of how the needs that we are expressing here, if opioids, or at least opioids, the misuse of opioids disappeared tomorrow, these services, these needs still exist with different substances as well. We'll highlight some of the efforts that are underway in DCYF and then also call out the urgent demand for more services, more resources. To ground us in the DCYF strategic plan, helping families in our community who are dealing with substance use disorder has been part of our agency's strategic priority since the foundation of the agency. So these come from our original strategic priorities, our strategic plan. Two main areas of that plan really speak to this. One is safely reducing the number of children, youth, and out-of-home care by half. And so this, we want to make sure we're ensuring that families have access to treatment as well as safety planning so that we can keep children in their homes. The other is creating successful transitions for youth and young adults who are exiting our care. So this is thinking more about the young people who are leaving child welfare or who are leaving our JR systems. And again, ensuring that they have access to SUD treatment and services as well. And you'll see, not that I expect you to dig too deep into these, but really even in the founding of DCYF, we called out this need for access to treatment and access to care. We also, as one of our target populations for our strategic plan, call out the need to make sure we're supporting pregnant women with substance use disorder and making sure that there's access to services for that population. So this has been a key focus of DCYF since the foundation of DCYF and continues to be an area that we're leaning into.
Sarah, can I take a break 1 second, ask a question? And that is, would you like us to wait if folks have questions and I can kind of keep my eye on hands, or what's going to be the best way or would you like people to kind of write their thoughts down and ask at the end?
Thank you, Senator Wilson. I should remember to lead with that at the beginning of a presentation.
I forgot to ask, so we both didn't, so it's all good.
Next time around, we'll get it. I think probably easiest, I'll go through my section, pause for questions, and then have each of our presenters present, pause for
Excellent.
questions, and then at the end, if there's time, we can have more broad conversation too. Thank you
so much. Just wanted to make sure our members knew as well. Thank you.
Appreciate it. As we're talking about substance use, I wanted just to highlight this visual about the continuum of care. Sometimes we think just about treatment or just about prevention, but really this continuum of care is an essential way for us to think about substance use. This includes prevention, harm reduction, interventions, treatment, recovery, and maintenance. And this isn't linear, and people don't come into this process at a certain spot. That people can enter the process at any spot and may not actually move through the entirety of the process. I have clinicians on this call who can speak much more eloquently about the continuum of care for substance use, but I want to make sure we're framing this not just as, does someone have access to treatment, but really thinking about all these different areas within this continuum that people may need access. So thinking about this as a holistic framework, as a comprehensive approach to how we address opioid misuse and addiction, rather than thinking about just access to one of these 5 areas. And you'll see our presenters will talk a bit about how the project or the work that they're highlighting may fit into one or multiple of these parts of the continuum of care as well. So I always try to bring a little bit of the evidence or the research about what we know outside of our agency as well about best practices around the topic we're discussing today. So here's kind of what the research tells us about opioid use disorder and the continuum of care. One, we know that cross-system collaboration is critical for prevention as well as access to treatment. And really there's 2 key components of that. One is working with providers to create a rapid referral response. So making sure that people can quickly have access both to behavioral health treatment, but also medication. This means also that our referrers, if there are folks in DCYF, can collaborate and partner with those treatment providers to assist in engagement as well as motivating folks to continue during the treatment process. The other is co-developing caseworker training. So ensuring that our caseworkers or JR staff are knowledgeable about opioid use disorder, are knowledgeable about opioid misuse, and have the opportunity to learn and to ask questions. The literature shows that co-developing these trainings is really critical rather than coming in with kind of a broad training on the topic area. Ensuring that it really is focused to the population that the staff are working with is critical. Next is safety planning. So working with families to implement home safety strategies and also training families on the use of naloxone. Residential family SUD treatment is also a known best practice. This is the ability for family members to go through treatment while also having their family with them. So think about a parent in treatment who's able to have their children with them in that setting as well too. And finally, universal screening for substance use disorder or substance use need, both for young people who are in out-of-home care, but also in the juvenile justice settings. So again, this is what the evidence is telling us we should be focusing on, as we try to address and meet the needs of our community. A little bit of data just to contextualize things. This is not looking at opioid use disorder, but more broadly at families with substance use needs. In the past year, a quarter of children who are in out-of-home care, parental substance use was a contributing factor for their removal from out-of-home care. So this is not specifically opioids, we're saying, and it's not only substance use, but for a quarter of those out-of-home care, substance use was at least one of the contributing factors for why the removal occurred. So we know this is a significant issue within our child welfare population. This figure is looking at access to treatment for our families in Washington State. The figure, and this was created by our great partners at RDA at DSHS. The figure on the left-hand side, or the map on the left-hand side, is a little bit dated, but it shows of parents who are, I should say caregivers, excuse me, with child welfare involvement and identified substance use disorder need, the proportion that had access to treatment. So again, these are caregivers who have an SUD treatment need and were able to access treatment. And the darker colors show areas where people were able to access treatment. The lighter colors show areas where people were less likely to access treatment. So you'll see the right-hand side of the state, the east side has less access to treatment for those needs. The west side has more access to treatment. That being said, that access maxes out at 60%. So it's not as though there is universal access to SUD treatment on either side of the state. There's just variation in access. And as I said at the top slide, we know for fatalities nationally, or excuse me, statewide, that our rural areas have seen the highest increase in fatalities related to opioids. So just highlighting this need in our rural communities for access to treatment and implications when access to treatment and resources are limited. On the right-hand side, I have a little bit more contemporary data, and this is looking more specifically at opioid use disorder. So again, these are caregivers with child welfare involvement, but now we're looking at an opioid use disorder treatment need, rather than the more broad substance use disorder treatment need, and then looking at the proportion who are able to access treatment in their community. And you'll see, and you can see the map on the left, so you know where our regions are, and I know you all are experts on DCYF and our regions as well too. But you see in this case, regions 4 and regions 5, which are our King and Pierce areas, actually have the highest rate of unmet need for MOUD. So that's medication and opioid use disorder treatment. So something for us to think about. Again, there's variation in access to substance use disorder treatment broadly in the state, and there's access and variation to substance use treatment specific to opioid use disorder as well. There's still a lot more digging in that we need to do with this data to better understand where to target services, but hopefully the broad takeaway you have here is that there is a universal need for more treatment access, and there's also pockets where we have significantly more need. And as we want to make sure that families are able to access treatment as part of their safety planning and as part of their efforts to keep their children in their homes, we want to make sure that access to treatment is available. Talking about our juvenile justice population, this is a look at a snapshot of our recent JR population of young people who are in residence. We see here that almost or over 3/4 of young people who are in JR, 78%, are indicated to have some sort of substance use disorder need. I want to pause there because that's really impactful. At least I hope that's really impactful to say 3/4 of young people in JR have that indicated need. Of the ones who are assessed more thoroughly for SUD treatment need, half are diagnosed with an opioid use disorder. Amongst that population, over 3/4 have completed treatment while in JR, and at this time when this data was pulled, many of the other young people are in the process of completing treatment as well. So we're continuing to increase access to treatment within the JR system, but important to understand the high need that's coming into JR when we have young people entering our system as well. And this slide really kind of highlights that as well. This on the left-hand side is showing the behavioral health needs as well as the substance use disorder needs of young people coming into JR. So prior to their entry into JR, they had access to Medicaid. Most of our population has Medicaid access, so we use this to track access to services moving forward. You'll see down in the corner over here, we see only 8% of young people had only substance use disorder. But 48%, half of folks come in, had co-occurring substance use disorder treatment need, or excuse me, sorry, yeah, the co-occurring substance use and mental health treatment need. So we have this population of high need of folks who have mental health and substance use disorder treatment coming into JR. And as you all know, the young people who are in our JR system exit our JR system and return to our community. So you'll see on the right-hand side, these are our young folks who are leaving JR and or on Medicaid who have access to treatment upon leaving. So within the 3 months after leaving JR, only 14% of young people who need substance use treatment are accessing SUD treatment through Medicaid. You'll hear later from our colleagues in juvenile rehabilitation who are doing the POST program, and POST is actually offering services to these young people. So access to services post-release is higher than 14%, but still, it's again important to highlight this high need when young people are leaving our system with a limited access to services. So before I jump into our next presentation, I will highlight again kind of the big space of how we're going to go through this. I want to make sure we're thinking about this, one, not just as a DCYF problem to solve, right? So these are issues that are universal issues that multiple systems will need to be able to resource. Also thinking about the complexity of this, the needs at the community level, thinking about the needs of parents and families, thinking about the needs of young people who are in our institutions, but also young people who are in our communities. And then thinking about services that are provided by DCYF, services that are contracted by DCYF, services that are referred to by DCYF. So we're not going to get into kind of all the nuance of that there, but there are so many different levels of the way we offer services, we offer treatment, and the needs as we think about the continuum of care from prevention to maintenance that we're trying to address throughout DCYF. And we'll touch on a few of those here. I will pause. That's the end of my piece. Ask any questions about the data or the context, and then I'll turn it over to my colleagues.
I see Mary has her hand up.
Yeah, hi, Dr. Bailey. I wanted to go back to, I think it was slide 8. Just curious around the table on the right-hand side. So I guess I'm just curious, like the difference between those people who don't have access to OUD treatment and those who maybe didn't access OUD treatment for like what could be a variety of reasons of why people and families can't or don't access treatment. So it's not necessarily, my assumption is it's not necessarily only that they didn't have access, but maybe there were other factors that prevented them to.
Yes, correct.
attend.
So that is
Okay.
not simply an indication that they were seeking out the treatment and it was nowhere to be found. There are other reasons why people wouldn't access treatment. Thank you, Mary. I appreciate that clarification.
Thank you.
I had a question, Sarah. You mentioned RDA. Could you tell me what RDA is?
Sure, research and data analysis. So they're
Thank you
the
very much.
data partners
Thank
at
you.
DSHS. Yeah.
Any other questions so far? And I think you have a team here to introduce as well. So maybe this is a good, oh, I see. Ruth has her hand up.
Thank you very much for this information. I'm just curious. Medicaid is obviously key to access to treatment. Do you think that the eligibility of these youth will be impacted by the bill that passed Congress recently?
I suspect it will. I mean, cautious about without having done a full review about making any definitive pieces, but there is certainly risk.
Yeah, just to add to that, I think there will be, I think the requirements around work and pursuing work, the requirements around having to reapply every 6 months instead of annually. So there are barriers or friction points. There isn't necessarily a change in eligibility, but I think there will be an impact on sort of the added demand that individuals need to respond to achieve and retain coverage. There is in the changes around Medicaid, a 90-day exemption of those requirements post-release from a carceral facility. And so at least getting it set up and trying to have things in place as the young person or as the individual is approaching and navigating those first few months of release, it won't have an impact there, but in terms of long-term retention of coverage, I think there is likely to be some impact.
Ted, can I ask if you were just then speaking around the 1115 waiver? Is that what you were speaking about? Because we do have an 1115 waiver and was with our Department of Corrections and now has been expanded to the JR space with Medicaid and not suspending and maintaining Medicaid, but also pre-release. I'm just curious because I've heard so far that has not been touched, but I don't know.
Yeah.
Yeah.
The waiver hasn't been touched.
Okay.
The things I think that I was speaking to are the changes in requirements around eligibility that after that
Right.
90-day exemption could have an impact on
Okay.
that maintaining coverage.
Thank you.
Yeah.
Thanks. And I'll add that our partnership and prevention services folks are looking into this right now because they are well aware of the potential impacts too. All right, well, I got my team here and you already had an opportunity to meet Ted Ryle, but I'll give a quick moment for Kim, Michelle, Ted, and Jimmy to do introductions, and then we'll transition into their actual presentations. I have it alphabetical here, so Kim, I'll have you go first.
Hi, can everyone hear me okay? Okay, thank you. I'm presenting from Colorado. I'm at a conference right now, so in an unfamiliar room. My name is Kim Ahrens. I am a pediatrician and adolescent medicine specialist, and I'm the medical director for DCYF JR.
Good morning. I'm Michelle Balcom, and I am an early learning program manager in our partnership prevention services team at DCYF and the statewide lead for Plan of Safe Care and our pregnancy SUD pilot work.
Good morning, all. I am Ted Ryle, clinical director for juvenile rehabilitation.
Hello, everyone. It's good to see many of your faces again. I'm Jimmy Ballenboyce. I am DCYF statewide SUD program manager. Also lived experience of over 20 years, MSW, a Master's of Addiction Studies, and several decades of working with the community in the field concerning substance use disorder.
Thank you all. So you see we have an expert panel here. So hopefully I set a good enough context so they can really get into the work here. Also, you can see that the context or the depth of the work they're doing couldn't be covered in the 10 minutes that they're each allocated. So just know we're gonna talk at a high level, but happy to dig into it deeper as we move forward. I'll run the slide deck to let me know as you want slides advanced. I'm going to skip forward throughout the slides I just did. So for folks who it makes you motion sick to see slides roll, I'm going to do that quickly now. And we'll get to Michelle's slides so she can begin. Perfect.
Well, once again, good morning, and thank you for the opportunity to share a little bit more information about Plan of Safe Care and the pregnancy SUD pilot. You can see here on this slide just an overview, again, very high level, as Sarah said, about who is required to have a Plan of Safe Care in Washington. And we really see that both of these programs, the Plan of Safe Care and the Pregnancy SUD Pilot, present us with opportunities to support families across the SUD continuum of care, from prevention to recovery and maintenance. We see these opportunities primarily through our partnerships and collaboration with our internal partners, our other state agencies, tribal partners, local community organizations, our service providers, and centered at that is our families with lived experience. The Plan of Safe Care is a family-centered prevention plan that occurs after the birthing event. And there are two pathways for Plan of Safe Care. So when Washington implemented this federal legislation, we chose these two pathways. One, to go through DCYF if the family has an open child welfare case and meets the criteria for child welfare intervention. And then the second pathway is when newborns with prenatal substance exposure do not meet the criteria for child welfare intervention. And that's when a Plan of Safe Care is completed through the community-based pathway with our partner, Help Me Grow Washington. So on this slide, you can see the process that a birthing hospital staff use when they have a newborn exposed to substances in their care. To date, we've trained 51 birthing hospitals, which is 94% of all birthing hospitals in the state, to use the Plan of Safe Care online referral portal. The portal helps guide the birthing hospital staff regarding their mandatory reporting requirement. So in essence, to help them determine if a call to intake is required or if the Plan of Safe Care can be completed through that community-based pathway with Help Me Grow Washington. That online tool includes a series of questions to collect information, and DCYF does receive de-identified data on those plans of safe care referrals through the portal. The questions also include gathering information about type of substance exposure, any safety concerns that are present, as well as supports and services that may already be in place. Additionally, the portal includes a bias check tool, and this was something that we added after initial implementation based on user feedback and collaboration with our partners. This bias check tool helps us to reduce bias in decision making. And if directed to the community-based pathway, the hospital staff continue through the portal to complete the referral to Help Me Grow. And Help Me Grow reaches out to the family to offer resources and services. A specialized team with SUD trainings, and they're constantly maintaining and upkeeping their up-to-date training on SUD needs in the community. They focus on engagement and meeting the family where they are to develop that plan of safe care together. And they help the family navigate the resources and services, and then they complete warm handoffs to providers. So on here, you can see some overall data since implementation. And what we're really trying to kind of highlight here is that the number of Plan of Safe Care portal entries have really increased since our initial implementation. But what we also do is really look at our regional information to see where we can focus more efforts to have more consistent statewide use of the portal. And on here, you can see that this is data available from our DCYF prevention dashboard. On the left, you can see that the trend over time is that out-of-home placements for newborns and infants up to 1 year old are going down and more recently have stabilized. And then on the right is information about our out-of-home placements for all ages. And you can see here that the highest percentage is in that newborn age range. And again, this is information available on our prevention dashboard. This is an important population for us to be supporting right now. So I do want to mention the pregnancy SUD pilot. This is an arm of the Plan of Safe Care work. So as I mentioned, the Plan of Safe Care is for after the birthing event. But in addition to Plan of Safe Care, the pregnancy SUD pilot, which we are kind of rebranding as we expand and it goes beyond a pilot stage as a pregnancy support pathway. This is an upstream prevention program. So prior to the pregnancy support pathway, prior to this pilot, reports to DCYF for a pregnant person experiencing substance use disorder were screened out. There's no born child, and there were no referrals and a high rate of being re-referred to DCYF after the baby is born, and subsequently a high rate of removal. Since implementing the pregnancy SUD pilot, when a report is made to DCYF intake involving a pregnant person using substances and that intake is screened out, the intake worker then makes a referral to the community-based care coordinator at one of these hub partners that you see here on the slide. And that care coordinator makes contact with the pregnant person and offers to enroll them in prevention services. And I'll just pause for a moment to highlight that some of our hub partners here actually center that lived experience and have peer navigators employed to help with those contacts, those initial contacts and engagement with the family, and have found that to be incredibly effective with engaging and enrolling folks into their program. So the goal here is to prevent future intakes, investigations, and removals related to substance use disorder. And Help Me Grow Washington, you can see here, is not only a hub partner in King County, but also can serve counties that do not currently have a hub partner. And we are, as I mentioned, looking to expand this work statewide and identifying how that will scale up from the pilot model. So since the planned safe care implementation, we have identified challenges and successes. One of the big things that we focus on is that this is a shift in the way that we all think about mandatory reporting. The online referral portal is that tool that I mentioned to help support that shift in thinking. So that bias checkpoint tool, our training, onboarding, and ongoing technical assistance for the birthing hospitals that onboarded for this initial implementation is an opportunity for us to really help create that shared understanding of safety concerns, what meet criteria for child welfare intervention, and to really build on consistent use of this portal. The strong collaboration and relationships that we have with other state agencies, not limited to, but including Department of Health, Healthcare Authority, our Washington State Hospital Association, as well as other external community partners and families, is so critical to achieving this shift in thinking and to build trust with DCYF. We are really working to create a statewide community that can support this work and support families. The usual challenges that come with organizational change and system limitations really do require us to do consistent monitoring and support to encourage that consistent practice, both internally and in the community. And so we are so fortunate to have amazing champions already within the child welfare space, within DCYF, and our great champions in the community. And we invite them all to attend a monthly Plan of Safe Care Community of Practice meetings. And we have found this to be so impactful for just supporting one another in this work, learning together, and really helping to inform ongoing decision making. So what we're doing next, as I said, we're continuing to make efforts to complete training for our 3 remaining birthing hospitals in the state. And we're in the process of developing an online Plan of Safe Care training platform so that as we add on more referrents in other spaces, maybe other medical providers, we're looking at in the future SUD providers, just really, anyone that we think can really have a wonderful, engaging opportunity with families to do this work and use the portal. So over time, we want to add as many more referrents as we can. Initially, we are looking right now at strengthening relationships with our NICU staff. So primarily with onboarding birthing hospitals, we've been looking at our labor and delivery and social work departments who are primarily tasked with supporting those families who may need to be referred to child welfare or community-based pathways. But we really see the NICU staff as being uniquely placed to engage families around relapse planning, harm reduction conversations, and just another opportunity to engage with families around that continuum of care. And we just, as I said, really feel that building and maintaining these strong relationships and continuing to focus on building trust with community partners is so important to expanding the Plan of Safe Care work and the pregnancy SUD work. We really review these relationships as an intervention in itself. This is gives us many opportunities to engage with families at different points. And we hear from families that they are more readily trusting of community partners than they trust DCYF. And so we really want to support those folks that families already feel that they have that trusting relationship with. And we really see that we, through those relationships, we have increased opportunities to collaborate and learn from those that provide direct service. And I'll say it again because I think it is so important, but to include that family voice in our decisions as we expand this work. So thank you so much for your time. And if we have time before I hand off to Jimmy, I'm happy to answer questions.
Thanks, Michelle. I'm going to transition to Jimmy just because we only have about 18 minutes left in our time, but if we have time at the end.
I think we can add a few minutes. So just because we had a little bit of a change in our agenda. So let's maybe allow for a couple questions if there is one. I see Dr. Leiby's got one. Sarah, thanks.
Hi, excellent presentation. I'm a developmental behavioral pediatrician. I have 2 quick questions. One is it's sort of speaking to this issue of trust with the families. I'm assuming that this is mostly voluntary services. And so what's your sense of how many folks will actually opt in for the services? So that's number 1. And number 2 is in pediatrics, we have a big belief in early relational health and supporting parenting relationships. And I wondered whether that's part of your interventions.
Oh, I love that. So in the Plan of Safe Care, that is through the DCYF pathway. It is not optional. However, it is very much family centered and focused. It is part of the caseworker's requirement to create that Plan of Safe Care. In the community pathway, yes, it is voluntary. And in the pregnancy SUD pilot work, it is also voluntary. The idea is we really are trying to begin that relationship and really help build, again, that trust so that families, even if they don't opt into every available service at that point in time or any services, we hope that they are having that positive engagement with the community provider, with either the care coordinator in the pregnancy pathway or the Help Me Grow Washington specialized team that really is encouraging to call back at any time, helping support them with information they can refer to later if they opt out. So again, just looking at it on a continuum of where can they kind of go, oh, that was a really kind person that helped me, and I hope I'll go back to them if I need them later. So in that, and then in terms of parenting, yes, we are looking at family-centered. So again, it's sort of where one of the reasons we're looking at the NICU relationship as a really wonderful opportunity is that while NICU staff have reported to us that they see the baby as the patient, as we've been engaging with them, we're really opening up those conversations of, well, with family, this is an opportunity to talk about parenting, talk about this child's unique needs, talk about, that relationship, that parenting relationship, and really working with the parent when they're in the NICU with their baby. So again, that's not the only, obviously, parenting component and focus, but within the community pathways, there are a multitude of services across the state that can help with not just parenting classes, but play groups and other peer supports and other opportunities to really support the parent with their work. And we really highlight early learning as well in our plans of safe care. So our Head Start, our ECAP, our licensed childcare programs that we really see as an opportunity for another support system for families to learn about child development, learn about their child, and have a community of other parents as they're parenting their children. I hope I answered those questions. If not, please tell me what else.
Awesome. All right. Thanks so much. And I think, oh, Ruth's got her hand up.
Sorry, one quick question. Are those families automatically eligible for Working Connections childcare? Can they get childcare?
It's a great question. That is obviously something that is in both pathways. So in Plan of Safe Care that's open in DCYF, we have child welfare continuing childcare eligibility, which is just going to happen for any open case or cases that close, and we have timeframes around that. And then there's a transition to ongoing eligibility for Working Connections. For those who are referred to the community-based pathway, that specialized team at Help Me Grow is able to help connect them and, like I said, kind of now help them navigate and do warm handoffs to get enrolled and determine eligibility for Working Connections. So they'll really walk them through that, as well as other things like, are you on WIC? Let's help sign you up. Do you need paid family medical leave for your, after the birth of your child? Let's get you signed up for that. They're amazing at navigating those resources, and they don't just give a link. They really help get folks, fill out the paperwork, and they're not case managers, but they're really excellent at navigating those systems.
There is concern because we did not fund and did not appropriate dollars for our Birth to 3 early ECAP program this last session, and we had money in 6109, which was a piece of legislation to look at our fentanyl response and how we're supporting not only those in the field, but also children and families. Deep concern there, and then also federally as we look at what's happening with Head Start and the decision and the executive order around no longer allowing undocumented families to take advantage of the federal program, meaning that we then also have to consider how our state may absorb some of those children and families that would be eligible. And childcare is an option. However, we also know childcare providers deeply need resources and supports and comprehensive services that our eligible families in our state and federally funded programs get, which is not available oftentimes for providers. And so there's a system issue here as we move forward. We have to continue to pay attention to, and just a deep appreciation for the Help Me Grow system, which I've sat in and listened to calls that care providers have made back to families who have either been referred or have made a call themselves. And so I think, you know, it's one of those areas we have got to consider as we think about the dollars invested, much more return on investment if we think early and often. But we have some really critical impacts. This happened this last session that I think we're going to have to keep our eyes on to make sure we continue to think about how we support this particular population. Yeah. Jimmy,
Everyone.
you're on.
Transition us to Jimmy. Jimmy, let's keep it, we'll try to keep it around 8 minutes still as we planned. And hopefully Senator Wilson, that will get us done around 10 after.
Jimmy, we can't hear you.
Looks like we might have lost Jimmy. So I think what we will do is we'll move on to our JR presentation. Then when he comes back, we can move back to his presentation.
Okay, I
A little bit out of
love
order.
I love flexibility. Thanks all.
All right, so I'll turn it over to my colleagues, Ted and Kim.
Hi, I am going to present, we just have a couple slides actually, and I'm going to present the first one and Ted is going to present the second one. Apologies for this being so small, the print, and I will just talk through it verbally. I think one point I want to make kind of at the front end is that on the spectrum of prevention to treatment and recovery and maintenance, we have services in JR that run the gamut. That's been a very intentional position for us. Starting at the top upper left and going all the way down to the bottom right, we're starting with sort of more preventive interventions, lighter touch interventions, and then moving down to more in-depth treatment-oriented interventions. So we provide opioid and overdose prevention education for every youth and have a focus on harm reduction. Education for staff as well. It's important for staff to understand the risk of overdose for our youth is much higher than it is in the general population, particularly the period right after folks leave incarceration. Is a high risk period for people in general to overdose, youth included. So we provide, we offer naloxone, a couple of doses of naloxone to every youth leaving JR. If they have a history of opioid use, we actually offer, instead of 2 doses, we offer 4. We teach them how to use it and talk about how even if they don't have a history of using opioids, that a lot of them have witnessed overdoses, have family members that have a history. And so there's very few youth that aren't touched by the opioid crisis in some way, shape, or form. We also train our staff 5 to 10 years ago. Our CPR requirement could be filled a number of different ways. We now require all folks to do it on site at one of our facilities in person. And we integrate naloxone into the CPR treatment. So it's airway breathing, naloxone, administer naloxone while you're calling 911. And I think that has been life-saving and is probably the direction that the entire nation is going to go in terms of CPR training in the not so distant future. We have a requirement through we are by policy required to be credentialed by the National Commission on Correctional Health Care. We're required to do drills and we're required to do yearly drills. We focus a lot of these on overdose events so that staff and nursing staff are able to respond appropriately. And we also have implemented a lot of enhanced screening of staff and visitors. I can't really read that one because it's really light. Let me see, I'll find it on here. Comprehensive substance use screening and treatment. Yeah, so for all youth, and OIAA has been a great partner in this. 5 years ago, I think there were a lot of youth who were getting missed, who had opioid use issues, and that is a very, very rare event now. Just rigorous quality improvement efforts have really made that our screening much more effective. And youth are offered treatment while they're in JR in our community facilities. We try to also connect them as they leave. Ted is going to tell you more about that. We also do routine and indicated drug screening while youth are in our facilities to try to reduce the amount of substances that are available in our facilities. We have a critical incident review team that reviews all critical events, including events where drug use has occurred and overdose risk is there. We do, for youth who have moderate to severe opioid use disorder, we offer medications for opioid use disorder, including long-acting injectables, Sublocade or Brixadi, and then offer evidence-based medical treatments for other substance use disorders as well. We have worked really hard and had a real focus on our transition support for youth. And I'm going to hand it over to Ted to talk more about that.
Thanks, Kim. Good morning, everyone. Again, my name is Ted Ryle. I'm the clinical director for juvenile rehabilitation. I joined the organization in 2002, so been around a little while, and I joined when we were implementing a statewide integrated treatment model, and my work in JR for those 2+ decades has been around improving what is available in terms of treatment services for young people and equipping staff to be able to engage and support young people in participating in those treatment programs. And I feel good about the information that we're sharing today and what it represents in terms of progress, because I actually resided in the JR system from 1980 to 83, and during that 3.5 years received exactly 0 treatment, and just know how important those interventions and supports can be. And this particular intervention that I want to talk about here is the outcome of work that began in 2019 in a very close partnership with Kim and Seattle Children's Hospital and the University of Washington, Sarah and her team, to be able to apply for and successfully get a grant, a 5-year grant that involved 2 planning years and then 3 years of a full study that included within it a randomized controlled trial. And it was a voluntary study, meaning the young people who participated in the study did so voluntarily. Initially, when it was just the study, it was an opioid prevention study. And our approach to it was opioid prevention by way of opioid and overdose education and substance use intervention. And so young people who were moderate or severe opioid dependent initially were not eligible for the study. And what we learned over the course of the initial period of the study was that young people tended to underreport, meaning that young people with moderate to severe ended up volunteering for the study, but then needed to be pulled from the study data because the study was for young people who didn't have moderate to severe. And nonetheless, it also appeared to be effective, effective at engaging and retaining them. And so they received the service, but were not a part of the study. The service is provided by Seattle Children's Hospital interventionists, which was actually a very important early decision point for those interventionists to not be DCYF staff. They're external interventionists and coaches who come into the facilities or contact the young people via telemedicine in the several weeks prior to their release and start to engage them and establish goals and think about service connections during that period of time pre-release, and then continue to provide support after the young person returns home, to varying degrees depending on how they are situated within the randomization of the study. But all of them received some support, which was a very important decision point early on as well. The model is based on an approach called the Adolescent Community Reinforcement Approach, Assertive Continuing Care, ACRA-ACC, which is an evidence-based intervention. Another decision point that was made that I think was really important was the study does not require the interventionists to be a credentialed SUDP. Instead, they're hiring for skill and fit for this particular population, and then providing really robust clinical supervision and training. And it has appeared to be effective in terms of recruiting quality individuals to the positions and retaining them in them, and in terms of their outcomes with being able to engage young people in the program. The third bullet just kind of touches on what are some of the key pieces that they are, approaches they're using and the focus of their work. They're really trying to establish goals and connect to services and supports with young people with a sober and healthy lifestyle in mind, while at the same time recognizing that they need to meet the young person where they are, that a harm reduction approach might be important. You know, what can we do to help this young person continue on a trajectory towards healthy, legal and safe living in the community? And so they're touching on all those things in order to be able to do it. They have been analyzing the outcomes data from the study over the last several months, and the initial outcomes are showing some really promising results in terms of reductions in marijuana and alcohol use. Kind of loops back to what I said about prevention by way of intervention, and so it would appear that it's having both that preventive impact on uptake of opioid use or escalation of opioid use, and also having an impact on alcohol and marijuana use. I think another important piece of data is that the retention or the recruitment and retention numbers have been really high throughout the course of the study. You know, 80+% or nearing 90% of young people who are eligible have opted in, and they've been able to retain of those young people, you know, close to 80%, 70 to 80% of those. Is there another bullet? I thought in an earlier,
Yeah,
in an
there
earlier
is. I
version,
think
there
if
was
you-
the recruitment and retention bullet. There it is. Okay.
Yep.
So this approach that kind of initiates prior to release and follows them into release, we know that is a critical time. It's a critical juncture, and those immediate weeks after release, we know things can go in a number of different directions, including sideways. And so having that support is critical. And there was a question earlier about the 1115 waiver, which is doing the very same thing. It's about that 90 days pre and post release window of preparation for and navigation into reentry. And we kind of have a proof of concept in how the post program has approached that. Another piece, just to highlight or reinforce something that Sarah said earlier when she was showing the data from RDA, that only 14% of young people received a Medicaid covered substance use service in the 90 days following release. That is referring specifically to services funded by Medicaid. And there have been a number of obstacles and friction points in terms of being able to connect or keep people with those services post-release. What these numbers and the post program are showing is actually a majority of young people are getting a substance use related service. It's just been funded through this grant and subsequently through some additional funding that we applied from our evidence-based expansion dollars to expand what Post was doing. And then the legislature also funded the program to continue, which was the whole intention of these opioid prevention grants, is to implement in a way where they can be quickly translatable to practice. And I think we have a good model here. And then just the other thing to touch on with Kim's slide, in the 21 legislature, there was some important funding so that we could increase the amount of substance use services that we provide. It helped us increase SUDPs in our secure facilities and established aftercare liaison contracts for our community facilities and in the regional offices for young people who have released to parole aftercare or who have released with no parole.
Senator Wilson, before we have questions for our JR folks, I just want to do a time check. I know you gave us additional time, but I also don't want to miss Jimmy's presentation.
Yeah, let's do Jimmy. We've got, we can go until 10:10 because we have a little bit of a change in our agenda. So certainly don't want to miss out, and glad that you could come back in, and technology sometimes is just a bear. So you're on.
I hope you guys can hear me. Can you hear me now? Okay. Yeah, that's wonderful timing on that. So, Sarah, you have done a wonderful job pulling this all together, and I really would like to emphasize that the 7 topics that I'm going to touch on are very high level, but they are very strong areas of focus. DCYF as a whole has made progress in each one of these areas, but there is so much more to do in the categories that I will be covering. And I'm coming from a perspective of both my personal community service with the homeless population, to our service to families that we serve, to our field staff and the tools they utilize, to the agency as a whole, and our interactions with other agencies and SUD providers. So the first is limited access. Many caregivers involved with child welfare do not receive timely SUD treatment, meaning that there is a very small window of opportunity sometime to get that parent engaged in service. And if they have to wait 3 or 4 weeks just to get their ASAM assessment or SUD assessment, that's a critical missed opportunity. Treatment penetration rates remain low despite identifying these needs. So we have formulated tools such as working with creating third-party SUD contracts where an SUD professional is working out of each of the regional offices to help bridge that gap and are able to provide SUD assessments, ASAM assessments, for clients who are not able to get it done within 30 days of their referral. However, we're limited to 1 SUDP per region, and that is due to funding. So that is one area that we could look at for expansion. Geographic gaps, available service in various areas throughout the region. Even as simple as locations for clients to do their drug testing and their UAs. There are some locations where a client might have to travel almost an hour just to get their UA completed. And if they do not have transportation, that is very complex. So we are doing workarounds like video oral fluid testing, where we are shipping the package to them. The UA provider is watching them on their camera do the test and providing instructions on how to seal it, making sure that it's in a sealed package and sent out. But those are just I'm just pointing out different things that we're doing in these different areas, but there is more creativity to be expanded on in each of these areas. Capacity issues, wait lists, and limited program slots delay engagement for clients. So our SUD facilities, a lot of them are maxed out, and you can really tell those who have effective services are more maxed out than those who do not. So it's really clear for our clientele. There are certain agencies, SUD agencies, that are more suitable. For example, if they're well balanced in co-occurring disorder treatment, SUD treatment and mental health treatment, combining those together, they are more utilized for our population, because the majority of our population that is impacted by substance use disorder does have some other type of co-occurring disorder with that. In addition to that, coordination challenges, lack of streamlined referral process between child welfare treatment and treatment providers, inconsistent communication and follow-up contributes to drop-off in care. So the biggest issue with that is that each region does not have the same resources as the other regions. So when it comes to referral pathways, there's limited bottlenecking in certain areas to reach those services. The next area is funding barriers, which we are all aware of. So funding constraints limits our ability for expansion, difficult in sustaining long-term recovery support for parents. It's easy to forget that treatment and the recovery process is a journey. It's not an event. So even after their involvement with DCYF, that service and that support needs to continue. That encourage motivational factor to keep them engaged needs to continue, and that will help from returning back into the system for whatever incident. And then the next category is harm reduction integration. For example, DCYF has been provided funding to receive naloxone and fentanyl test strips. We are really great at providing those to the targeted population who could best benefit from utilizing those. For example, I can say for a fact with our data that our naloxone kits have been successful in reversing 8,336 overdose reversals. So that is a very concentrated, successful rate. There used to be a point where our staff could not even carry naloxone, where they were not even trained to use naloxone, where there was no funding available. But even though we have access and we're able to provide it to our population, we still hear from our population that they have a hard time getting a hold of naloxone, and the primary source is if they're assigned to a social worker. We've had clients that were not part of, well, I wouldn't call them clients, but we've had individuals who were not part of our system trying to tap into our naloxone resources. So it's not as readily as available as it should be. The last category, and I feel like I'm talking like an auctioneer really fast, but I think we're 2 minutes over. Opportunity to the need for innovation. So the opportunity to pilot community-based models and expand harm reduction approaches, help with more education. There's not enough curriculums out there to help educate individuals on what harm reduction is, which primarily is meeting the person where they're at in their situation and helping minimize the damages that are occurring. So enhancing workforce training, building capacity, improving engagement. All right, that's it.
Thank you, Jimmy. Thank you for being an auctioneer for us. And hopefully we've sold you all on the importance of this issue. I won't say anything else now because we've gone over time, but I'm happy to respond to questions in writing, or please reach out and we'll make sure that we can set up some follow-up meetings as well too. Thank you all for your interest and your letting us come today to present to you all.
We always think we have plenty of time, and then we always find we don't have plenty of time because there is, in fact, so much going on and so much information, and my eyes get bad as I get older. So we did get a copy of the presentation, so I know individuals will be able to dig in and again have some opportunity to ask further questions if we've got that. So really appreciate that. And want to thank you, Sarah and Michelle and Jenny and Ted, and I know Kim had to jump off to get on a plane, but really appreciate sharing information and know it's critical that we see it, we know it, and that we have a way to help change the trajectory, if you will, for all children and families and young adults across the state. So that being said, you probably have places to go, but you're welcome to stick around if you'd like to do that as well. And I'm going to pass it off now to our executive director, Elisha Martzinitsin, who is going to give us an update on kind of the work underway around potential changes to our statute and to the work we may take on as an oversight board, and talking a little bit about themes from a recent meeting we've had about the board's history and potential future direction. I also know joining us is Sharon James, who is here from the Office of Attorney General, and I'm going to answer and also compile any kind of questions that may come out of this conversation. And then I believe after that, we are going to take, we're not, we're going to do some public comments. So I'm going to pass it right on to Elisha, but I promise there'll be a break coming up.
Wonderful. Thank you so much, Senator Wilson. And Nicholas will be driving my slides today, but while he pulls those up, I'd love just to get us started. So want to say again, good morning, everyone. My name is Elisha Martzinitsin. I'm the Executive Director of the DCYF Oversight Board. Thank you so much, Nicholas. That looks perfect. I'm delighted to be here to talk with you to discuss what the co-chairs and I have been describing as Oversight Board 2.0. So today you'll learn a little bit about how this process, how we kind of got here, began in 2024 and where it is today. Later in the presentation, as Senator Wilson mentioned, I'll be providing an overview of the board statute that was created by House Bill 1661 and codified into law as part of RCW 43.216.015, in case you're taking notes. And then again, as Senator Wilson mentioned, Sharon James, our Assistant Attorney General, is here to answer questions that you may have about the board statute. So together with the co-chairs, I really believe that the timing is right to explore future directions for the board, considering that the board has several newly appointed members. We have new DCYF leadership, as well as new staff in the governor's office, and of course, a new governor. Next slide, please. Great, thank you, Nicholas. So at a high level, starting in August 2024, when I began my role as executive director, almost a year now, I began working to understand the board's impact as a part of continuous quality improvement. And some of the activities involved in these efforts are described here on this slide. So for example, in August and September, I completed one-on-one interviews with all of the board members. In October of 2024, we had a meeting with all of DCYF leadership that included the co-chairs, as well as myself. In October, we had an all board member in-person retreat. And this other activities included meeting with advocates, lobbyists, particularly on the child welfare front, And an all-member survey was conducted in December, kind of asking questions about impact and future directions. And I think it's really important to remember the context within which all this work is occurring. And I, put this at the bottom of the slide. So in 2024, the Oversight Board was at the 5-year mark. As I've mentioned, there's a new executive director and we had relatively new co-chairs. So we were really thinking about where we want to go in the next 5 years. Next slide, please. Thank you, Nicholas. So in 2025, at a high level, continuous quality improvement efforts included the launch of 2 subcommittees, the Juvenile Rehabilitation's Outcome Subcommittee and the Annual Report Subcommittee, and those occurred in February and March. And then the Annual Report Subcommittee, in their work, really identified a need to, that they plan to recommend to the board to revise the statute specifically as it relates to the number of performance indicators. And that's something you'll hear a little bit about in our next meeting in August. Here you'll hear about those recommendations. There was also a listening session that occurred with those individuals who were involved with DCYF's creation. And we refer to this group as HB House Bill 1661 group. And that occurred in June. And then we've just started some work really digging into the statute. And then I'm pleased to say that an ad hoc statute change committee is launching, I believe, as early as next week, to study the statute and make recommendations to the board. And again, all of this is happening with critical context. As I've mentioned, a new DCYF secretary, Secretary Sen. We all know about the statewide budget deficit, and so much of what's happening in Washington is always in our minds. So next slide, please. So as I mentioned, in June, a small group of board members involved in DCYF's creation met to reflect on the board's history and explore potential directions for the next 5 years. And we really kind of looked at this meeting as let's look back to move forward. And the group consisted of Ruth Kagi, Dr. Ben DeHaan, Representative Dent, Bobby Bridge, and Lois Martin. And they were asked to address 3 questions, even though most addressed these questions in writing prior to the meeting. Again, really helping us to look back to move forward. And those 3 questions were, what was the original rationale for oversight? The second question was, do you feel the board has been able to carry out its function? And the third question was, what challenges do you see as we move forward? And co-chairs Senator Wilson and Dr. Diane Levy, as well as Nicholas and I, also attended this meeting as listeners. So in terms of next steps from this meeting, Nicholas and I reviewed the notes for themes and really created a list of primary takeaways. It's not exhaustive, but it's truly those items that rose to the top. Notably, many of the themes that we came up with were reflected in discussions that have been occurring this past spring in the annual report subcommittee group. Next slide, please. Okay, so these are the specific themes that we identified, and I'm going to go through them here, and then I'll unpack each theme in the subsequent slides. So very broad brush. The themes were board purpose and oversight clarity, legislative challenges and opportunities, strategic focus, prioritization and effectiveness, data evaluation and accountability. Number 5, proactive versus reactive interaction with DCYF. And 6, engagement and voice, both internal and externally, as well as a priority area selected by the board, and that was worker well-being, and I can provide some history about that. Next slide, please. Great. So first, again, this group was involved in the original creation of DCYF and the Oversight Board. And some of the things that, again, that rose to the top to them was board purpose and oversight clarity. And these were some of the notes. Original intent was active oversight with real power rather than an advisory role. They talked about lack of clarity around the definition of oversight, as well as the process for it. And this group felt that the board had broader authority than it had historically used. And some examples of that from our statute is that the board, for example, can receive reports from the Office of the Family and Children's Ombuds, as well as access relevant records, prohibited as long as, you know, that is legal. And then they can also request and receive information, outcome data, documents, and records from DCYF. And in a subsequent slide, I'll go over powers outlined in the statute. So next slide, please. So number 2, legislative challenges and opportunities. So the original legislation, this group really felt was overly prescriptive, limiting flexibility. And that's something that I foreshadowed around the number of outcomes that are in our statute to assess on an annual basis in our annual report, which is due to by December 1 to both the legislature and the governor's office. There are currently 18 outcomes in our statute that are defined. And to give you an example, in our most recent annual report, those 18 were further split into 34 different performance indicators, often because we want to look at these measures by things like race and ethnicity. So that, you know, leads us with a report that has 34 performance indicators that is quite long. The second issue that kind of rose to the top was the need to revise the statute to allow for adaptability and clearer focus. So actually less specificity in the statute with flexibility to change as needed. One example could be the Oversight Board will determine outcomes to prioritize and monitor biannually. And finally, really, there was this need to and desire to define the board's unique value relative to other bodies, commissions, and boards. Next slide, please. Okay, third theme that rose to the top, strategic focus, prioritization, and effectiveness. And so in this particular domain, we talked about, well, the members talked about focusing on fewer, higher impact priorities. We can't do everything. So narrow goals to a manageable set of high value areas to maximize effectiveness and avoid dilution of effort. Second, use subcommittees strategically. Subcommittees can help the board accomplish more within its capacity by advancing work on prioritized areas. And that's something that we're most certainly experiencing in the 2 current subcommittees, JR Outcomes and Annual Report. A lot of work is getting done, and it's sometimes easier to do that within a smaller group. And then finally, targeted oversight for greater impact. So well-focused oversight efforts can improve agency performance and potentially reduce state costs. So that was an idea brought up by this group as well. Next slide, please. Okay, so data evaluation and accountability. And I just have to say, it's been so lovely to collaborate with Dr. Sarah Veely and various colleagues at DCYF around these systemic issues related to education and substance use disorder treatments as a part of a continuum of care. And I'm just really grateful for their presentation at this board meeting, as well as our last board meeting in May. But there were some things we discussed at this meeting. The first being opportunities to improve the consistency of data sharing between the Office of Innovation, Alignment, and Accountability, OIAA, and the board. There's a desire for greater collaboration with OIAA, courts, and others, which they really felt could enhance insight. There was a little bit of discussion that surveys appeared to be underutilized and needed better design and use. And I think there's an important caveat there that was mentioned by Secretary Sen, as well as Dr. Sarah Veely, who is the director of OIAA. And that's the very real challenge of survey fatigue among DCYF staff, which is something that should always be taken into consideration. And finally, limited board staffing. So the DCYF Oversight Board is an agency of two. So it's me and Nicholas Colgan as our administrative coordinator. And having an agency of two constrains the ability to do things like conduct surveys and really do adequate stakeholder engagement. Next slide, please. Okay, number 5, 5 of 7. So proactive versus reactive interactions with DCYF. This group noticed a tendency to engage with DCYF post-crisis and felt that that was really counterproductive. And if anything, feedback after the fact could be interpreted as judgmental and less, not really aligned within a partnership approach. There's a need for proactive engagement to influence decisions early. And one example that was discussed was a challenge that DCYF has experienced to meet various federal requirements for to draw down Family First Prevention Service Act dollars, which has a major effect on prevention services that are available to children, youth, and families in Washington state. Next slide, please. Okay, 6 of 7. So engagement and voice, and this is both internal and external. So there was a feeling that there are gaps in incorporating the voices of youth and those with lived experience, and the desire to really get more input from our communities. And then overall, a need was expressed for stronger partnerships with stakeholders, unions, and the governor's office. And I think we are really making some strides in the domain of the governor's office, really being able to successfully partner with Mary Spruce Garland. And that's been a really fruitful partnership that we have been able to sustain, and are just thrilled for her partnership and her ability to be on the board as a non-voting member. Next slide. Okay, so 7 of 7, priority areas selected by the board. And so worker well-being, and this is one example of how we can prioritize one of several issues. And this has been a consistent concern of the Oversight Board. It was elevated at our 2024 retreat, and has really kept coming up as a priority. And some ideas that were shared at this meeting was that the workforce issues at DCYF are critical at this time and persistent. And the opportunity to really make a meaningful impact in workforce turnover is really critical, because it allows us to support retention and promote better outcomes for children, youth, and families. And there may be something in the chat that I did not see, but feel free to hop off mute if it's germane to this slide or any of the slides I just presented. Okay, so I'll keep going. Next slide, please. So next slide would be great if it advances. You never know with technology. So in sum, the overarching themes from this listening session centered on the board's purpose, prioritization of efforts, and overall effectiveness. And we're generally aligned with some of the discussions from the annual report subcommittee meetings. So really, this information was collected over data gathering efforts that, in great honesty, began in 2024. So just wanted to, and those were kind of highlighted at the beginning of my talk. So if we could please move to the next slide, which is statute. What's in our statute? What does it say? What does it not say? I am thrilled that AAG Assistant Attorney General Sharon James is here. And, after I do this brief overview, we'll be able to answer questions you may have, because it's not necessarily always clear. Next slide, please. So this is in our statute, and it's frequently referred to as the board mission. And I'll just read it because I think it's very grounding. The board is authorized for the purpose of monitoring and ensuring that DCYF achieves the stated outcomes and complies with administrative acts, relevant statutes, rules, and policies pertaining to early learning, juvenile justice, juvenile rehabilitation, and child and family services. Next slide. Thank you. So what are these stated outcomes? At the very broadest level, they include, and I'll just highlight some of them here because I want to make sure we have time for discussion, reducing racial and ethnic disproportionality and disparities, improving child development as assessed through school readiness, preventing child abuse and neglect, improving child youth safety, permanence, and well-being, improving reconciliation of children and youth with their families, improving adolescent outcomes, reducing the future demand for mental health and substance use disorder treatment, something that was discussed in our first presentation by DCYF today, and finally, reducing criminal justice involvement and recidivism. Next slide. So powers. Looking at our statute, we have identified, and these were discussed at the 2024 board member retreat, and I'll highlight some of them here. General oversight. So provide oversight for DCYF's performance and policies and offer advice to them and the governor's office. Information access. The board can request and receive information, outcome data, documents, materials, and records from DCYF, and that was mentioned a little bit earlier. Performance evaluation. The board can assess whether DCYF meets its performance measures for the stated outcomes with metrics disaggregated by family income, race, and ethnicity. Reports and records. The board can receive reports from the Office of the Family and Child Ombuds and access relevant records barring legal prohibitions. Investigations. This is number 5, can request investigation by the ombuds into administrative acts. And then there are some things in the statute that really have not been occurring that are considered a power. So for example, contract reviews, conduct annual reviews of DCYF service contracts, including contract measures to ensure they are performance-based. This really has not been occurring. Service delivery assessment review surveys and may conduct additional surveys to evaluate the effectiveness of the department's services. There's some language in there specific to licensing reviews as it relates to child care facility licensing. And then, of course, the board has the authority to select officers and adopt procedural rules, bylaws. Next slide, please. So I am hoping that we can have a robust discussion, particularly with Sharon James here, about any questions you may have about some of the findings from the listening session. I know board members who were at the listening session are here, and you're more than welcome to chime in if you feel like some of our interpretations perhaps weren't on the mark. But just really want to open it up to people so we can talk. And I believe we have till 11 a.m. So don't all jump at once. Ruth.
So I see Representative Dent also has his hand up, and we obviously had a lot to do with the drafting of this bill. And we had a very ambitious vision of what this board could do, but didn't give the board a staff of 20 to do the work that was set out in the legislation. So I do think, Lisha, that the summary you've provided really does focus on some of the decisions we need to make about focusing more and having strategic priorities so that the recommendations we make really are based on some in-depth understanding and will influence the governor's office and the legislature. And I think the kind of very, the effort we've made to comply with giving information on all the specific outcomes in the bill is it hasn't been value added. So I think it really has limited the impact of our work. So I really commend you and the co-chairs for the work you've done to dive deep into this and to really help us think about how we can be more value added in the future.
Thank you, Ruth. Representative Dent.
Thank you. And thank you, Ruth, for those comments too. We did work hard on this and we did have an ambitious agenda. We did. And, I think we still do. I haven't felt that go away yet. But I just want to comment on this presentation you just gave us, Elisha. Excellent presentation. I think you really captured a lot of the ideas that we've had and the concerns that we've had. And I'm really anxious and looking forward to hearing from the rest of the board on their take on what we've just presented here and kind of get their feelings on how we could maybe proceed. But I really believe that we're on track here to maybe become a more a bigger player, I guess, in the game here with DCYF, because I think we're all passionate about our children and their futures, and I think this oversight board can help. We all know that if you're one step removed from something, you have a better shot. You see it better. It becomes more clear. And that's why sometimes we reach out. Why do we go talk to a friend when we're having issues? Because they're one step removed and they can give us clarity. So looking forward to hearing from the other folks, and I thank you for your hard work.
Great. Thank you. And thank you for all your hard work for those folks who created DCYF and the Oversight Board. I see Dr. Levy has her hand raised.
Yes, Elisha, great job on just pulling it all together, I think, in a very easy to understand, well, maybe not easy to understand, but a very concise fashion. I think one of my questions, and maybe this is for Sharon, has always been the process by which we do the oversight. You kind of went into the powers, but the question I've always had is, okay, and then what? And it seems like from my reading, most of what we've been doing is doing the annual report and providing that to the legislature and the governor's office. But I wondered if there was anything else that you could pick up through the statute reading that maybe I'm missing about how we actually affect our oversight, if you would. Where does that, if we make recommendations, for example, where does it go? I just wonder what the thoughts are. Maybe other people have questions about that as well.
I would say for me as a legislator, when I get the report from DCYF, from the Oversight Board, then that would be something I would look at to see if there's any relation or any work coming out of the recommendations of the reports that are made by the annual report that could be worked on as far as a piece of legislation goes. But I also believe this is kind of the nuance area where this is a gubernatorial appointee. And so when you have an acting secretary who really reports to the executive branch, then the oversight board, it's an interesting thing when we talk about oversight, because we really don't have oversight over the secretary at all. You know what I'm saying? It's kind of like it is very different than any other agency. And I think that's the other thing I'm still challenged with is what is different about this particular oversight board or commission that's different than others. And because I too, Diane, we can do all the things in the world, but they only go as a recommendation really, but then to the acting secretary, to who would then take them to members of her agency, or to the executive branch, and then Mary per se as the person who sits on this board as someone who represents the governor, perhaps there. I don't, that is really a good question, because that's, I think, where we don't necessarily have clarity and it becomes just a report. Right? Anyway, I appreciate that wonder.
Yeah, Laisha, can I chime in here too? Just
Absolutely, please do.
yeah, I mean, I just have some thoughts. It is such a, I don't know anything super concrete, but it is just a very unique kind of space. And I'm trying to think of like, okay, where were we really trying to go? I know there was a lot of history with Children's Administration at the time, and I think the broader stakeholder community not feeling really engaged in that work or an ability to be engaged in that. And so I think, and I'm also reflecting, Laisha, on like some of the pieces that were the board has previously had a tendency to be kind of reactive to the crisis. And I think what some of this, I think of it more as like maybe advisory, right? As like we want to help direct DCYF on priority areas and influence the, in taking the workforce well-being, like influence the agency on really prioritizing that and putting together, recommendations and, projects or whatever, things that they can do to support the workforce. So I don't know necessarily if it's completely advisory, but it does feel like the more of a strategic direction conversation would almost be more of a value to a group with the expertise such as the oversight board versus this kind of like reactionary stance where something happens, board members didn't love it, but there wasn't actually really a function to change that in any way. So more of kind of like strategic direction and priorities seems like maybe the better place to dive in, but these are just some kind of initial thoughts.
That makes a lot of sense to me. Really thinking about strategic direction of priorities, fewer priorities, and then how do we come together, for example, and really what would oversight look like, right? And I think those are some of the questions you're asking. And Sharon, I don't know if you could maybe chime in on Diane's question as it relates to process for oversight, because I know that's something I've grappled with as well.
Yeah, I don't want to get into too much of the, sort of nitty-gritty details, because first of all, I don't have those. I haven't been involved in the process before, but one of the things that I did want to point out is, yeah, there are advisory bodies, obviously, as you all know, that are created by the legislature. It seems like the oversight board is advisory, but also it has a purpose that's probably, a little bit over that line of advisory only. You don't have specific things in the statute that, enforces the things that you do necessarily, but you also have this collaborative piece in the statute that says, and I'm reading from the statute, that the board has general oversight over the performance and policies of the department and shall provide advice and input to the department and the governor. So you have the, the collaborative piece on that side as well. And then the report to the legislature. It kind of seems like you sit between the two sort of bodies. Well, actually three when you count the department, the governor, and the legislature separately. So that sort of sidesteps the process question, I guess, but it was something that I did want to point out, that there is that piece there as well, in addition to the report, and I hope that's helpful.
Yep, thank you. Other thoughts, maybe from people who haven't had an opportunity to share?
I see Rep. Dent's hand up.
Just a quick comment. Thank you. At our very first oversight board meeting that we held in Ellensburg, it was suggested that we were an advisory board. And I remember that our then chair, Ruth Kagi, made it very clear that we were not an advisory board, that we were an oversight board. And we all agreed with her at that time. And I think there are a lot of advisory boards, but it's not really where we're headed. And that somebody I think Sharon just read the advisory or an oversight definition to a point, and I think that's really very clear. It doesn't mean that we run the agency, but we can chime in on some serious issues that happen from time to time, and we should have a little bit of teeth somewhere. There should be some teeth in what we do. So anyway, thank you.
Ben, I see your hand up as well. Thanks.
One thing I'd point out that's unique about the evolution of the board is that the entire process was actually originated by the governor through an executive order. That led to the Blue Ribbon Commission conversations, and then legislation followed that, reflecting the needs that were identified by the Blue Ribbon Commission, which who did extensive research. And I guess the issue of oversight really turns on this question of how are executive branch agencies held to account when the legislature passes a new law anyway? It all goes back to the governor's office ultimately. You're right, we have no line authority over a gubernatorial appointee, but if we're engaged in a process that was originally created in the governor's office, which sought to create a partnership with the legislature to define what that accountability should be, a lot of the success of the board really does redound to how the governor feels about it and whether or not he sees it as intrusion into the executive branch by the legislature, or whether it's something that is, as someone said, is directly in the middle of those two branches of government. So we can't function in the way that the statute requires us to function without very strong support and understanding from the governor's office. It's just not possible. It's not politically feasible to do. And I certainly, being involved in this from the very beginning, the overwhelming complexity of what we're trying to do relative to all of the metrics is really the subject of the subcommittee that I chair. Hopefully we'll be able to come up with a streamlined approach that helps us define what oversight is and what level of support's necessary for it from the governor's staff. Excuse me.
Thank you, Ben. Other thoughts?
I mean, I guess I have a question around like, how would board members, what do we imagine that, like, Rep. Dent, you talked about like the teeth, like what would that, I guess, look like? I don't know that I've really witnessed that, but it's possible that, we have examples of like, hey, decision was made, oversight board came in and, disagreed or felt strongly about going in a certain direction, and then has the department then like taken that and, gone in a different direction as a result of oversight board input in the past?
Go ahead, Representative Dent.
Thank you. So maybe I can answer that, Mary, a little bit. So what we talked about a lot in the beginning was, watching the agency from the 30 to 40,000 foot level to see that they're on track, that they're going the direction that the legislature and the governor's offices, would like to see them go. There were concerns around the child welfare issues. That's why that's the Blue Ribbon Commission that was formed. And then that's what ended up in this, as a DCYF, and it was a highly negotiated bill, but I think everybody was really concerned about what was happening with our children. We wanted to have some oversight that they're doing the job that we want them to do. Okay, so I get the challenge here. It's really, really hard to kind of nail this down to, well, what is this exactly does that mean? But I do think we have to have the ability to challenge the DCYF to leadership or et cetera. So if we feel like they're not going where we'd like to see the agency go, that we can confront that. We can ask those questions and see what they come back for answers and kind of analyze it from there. But it's a hard question to answer. and we've talked about this since the very beginning. What does oversight really mean, and how do we get there, right? So I don't know that we're going to get there in a short discussion, but I think it's something that I really believe that we're on track to find a path forward. And what do you say is a 30,000-foot level? Okay, so if we see them. So let's say foster care. Okay, so we want to improve our foster care, we're helping these kids, get together and get a life. But we see the maybe we're not going that way. Maybe it's failing. Okay, maybe we're not holding that up to the standards that we want. And is that when we step in and challenge the standards that's being done, or challenge the methods, and we ask them, how can we change direction? And I think sometimes it's easy in an agency. In bureaucracy, that can sometimes, they get bloated. We all know that, and they can maybe not turn the corner very quickly. Okay, agencies don't change directions very fast, right? So maybe that's an idea. I'll give you that would be an example that I would have.
I've really felt like our first question is who is DCYF partnering and communicating with as they're coming up with the decisions and the legislation, because it's as if this is the only place, and this is not. As a matter of fact, there's a whole lot of work going on at different tables with different advocates and advocacy groups and supporters, people on boots on the ground. An example of that would be the recent JR subcommittee that was created for the Oversight Board, but there's also a JR subcommittee that was created through the Sentencing Guidelines Commission. There's also a JR table that's been challenged and working with our entire system over the last year. And so for me, I'm a systems thinker. It's critical that we are part of the conversations that are boots on the ground, and part of that, and that is brought forward to the Oversight Board, perhaps in support of, or what we need to do in addition to. But I would hate to see the Oversight Board driving the work, if you will, of oversight without making sure we're part of those ongoing table conversations. And so for me, it's like we have this incredible expertise here. And it's recently the ask, for example, and Dr. Levy, I'm going to use you as an example, having DCYF reach out to Dr. Levy and talk and ask her about her experience as a physician and a pediatrician in particular around the current opioid epidemic and what she sees in her work with children and families. That's an incredible use of the expertise in this room, and others just like Dr. Levy, all of us here could be additional resources in those kinds of conversations and bring that back to the Oversight Board as well. So I think there's an and both kind of conversation, but to me it's how do we find out and how are we part of those larger conversations already occurring, and how do we provide input into perhaps legislation and such. And I think that's been the conversation around getting in cadence with the legislative process and how it is that we're, as an oversight board, able to provide input also into the legislation that is coming forward during a session. Just some thoughts.
Just jump in really quickly. Something I couldn't agree with you more, Senator Wilson, about the concern about duplication of efforts, because that's not good for anyone. The Oversight Board has been working for about 9 months to really understand, working with DCYF to really understand who are they communicating with, who are they reporting out to, where is their duplication. So that's most certainly an active and ongoing effort. So just wanted to clarify that. I see Ruth's hand.
Well, I apologize. I had to step out for a minute. Someone was at my door. One of the limitations that we've experienced is the inability to get appointments filled. And I think, there's been tremendous progress made in the past several months about that. But for example, we have seen in recommendations like from OFCO, the role of courts and the importance of really engaging courts more in the work of child welfare or the communication. And it's just the example you used of Dr. Levy, Senator Wilson being called on. I think if we had someone appointed from the courts, which we did have for the first, for the first several years, and if we had a full oversight board, that our capacity to provide advice from our expertise would be greatly enhanced.
Thank you, Ruth. Well, any last comments? I'm noticing we're approaching 11, and I definitely want to say that this is something that is an ongoing conversation. As I mentioned, there's an ad hoc subcommittee really looking at the statute. We'll be actively involved with the governor's office as soon as we do a little bit of exploration. I'm really looking forward to collaborating with Mary on this, and hope to kind of continue the conversation at our next board meeting, which is in August. But if there are any last thoughts, please feel free to jump in. And just again, want to really appreciate those folks who, what I'm calling the HB 1661 group, who really took the time to talk about where the board originated from, and really where we'd like to see it go. Those are really important efforts, and just want to elevate that. So thank you.
I want to thank you, and I know you and Nicholas both spend a lot of time and figuring this out. So really want to thank you for that one, and just say we have a little bit of a change in our agenda, and I think Ben made it lost to his breath when he saw his name on the agenda. But just know that the annual report subcommittee report will be coming. Update will happen at our August meeting, and so with that, I am going to gleefully pass it on to my colleague in crime, and that would be co-chair Dr. Levy. It's all yours.
Well, thank you. And I just was going to add in that this particular discussion was really truly meant to make sure that all board members are aware of what's been going on. There's a lot going on. I should really try, and like Nicholas, try and keep us apprised of what's going on behind the scenes. But this is an ongoing process, and it will continue forward, and we'll continue to update the larger group, and you may get contacted for your thoughts. So if you have thoughts about this, please share them with us as we move forward. Okay. Thank you, Laisha, for sharing the update on your ongoing work. And thank you, Sharon, for joining us today. We are now going to move to the public comment portion of our agenda. And I'm going to start by reading the usual statement. So the DCYF Oversight Board operates under state law, which outlines its authority and responsibilities. Specifically, the board is responsible for monitoring DCYF's progress toward achieving outcome measures, ensuring DCYF's compliance with applicable laws and policies, overseeing DCYF's performance and policies, and offering advice and input to DCYF, the legislature, and the governor's office. While the board may consider information brought to its attention as part of its general oversight and monitoring role, it does not have the authority to investigate, direct, or alter DCYF's decisions in individual cases. Additionally, during public comment periods, neither the board nor meeting presenters can respond to comments beyond a simple acknowledgement. All public comments related to DCYF will be compiled and sent to DCYF leadership following the board meeting. And that is a change that we are now doing to make sure that you all know that giving public comment, this actually is there's a feedback loop that now goes directly to DCYF. To respect individuals who may have sensitive stories to share or wish to discuss details of individual cases, we'd like to remind you that the board is subject to the Open Public Meetings Act. This means that our meetings are open to the public, recorded, posted on the Oversight Board's website, and live streamed on TVW. Written public comments submitted in advance have already been sent to the board meeting members, and we had 3 written comments that everybody should have had the chance to review. And to ensure that everybody has an opportunity to speak, please try to limit your comments to 2 to 3 minutes. And I'm going to have to be a little bit tough on that today because we do have 6 folks signed up for comments. So I'm going to really try and limit to about 2 to 3 minutes. Okay, so without further ado, the first person for public comment is Kathy Elkins.
Thank you, DCYF Oversight Board. My name is Kathy Elkins. I'm an educator and advocate for child welfare, concerned about missed opportunities to protect children and false allegations. I'm following up with my request for DCYF to change policy 2350, which prohibits parents and caretakers from recording interviews during child abuse investigations. I allege that 100% of the documentation from these interviews is incomplete or inaccurate. You can't prove me wrong because there are no recordings that you are aware of. DCYF staff are expected to document conversations while actively participating in them, but research shows they can't. They can record about 1/6 at the most of what they hear, and that's when they're just listening. Staff might jot things down and write them later in the office. Worse, the training DCYF staff receive distorts their lens. In September 2021, this committee was given a MedCon presentation, which included a link to a course required for all new DCYF staff. If you had listened to it, you would hear these very concerning statements from Dr. Joyce Gilbert. This is what they learn before they start their job. Quote, stealing food from school is an abnormal activity. Children only do that if they're starving, unquote. Another quote, a child who does not move yet and presents with a bruise and had that bruise inflicted on them, and that is child abuse, unquote. That is not what the science says. Both those statements and others in that training are inaccurate. The studies that she is referring to, often cited by abuse experts, actually do find that bruises are concerning in healthy non-mobile infants, but they found accidental bruises. And based on those studies' own data, 51% to 92% of infants under 6 months would have at least one bruise in the 6-month period. Even the study authors believe that actual rate may be higher. A bruise should definitely prompt questions, yes, but it does not automatically mean abuse. DCYF staff are trained to suspect abuse and then asked to summarize conversations without recordings. That combination guarantees errors, and children are the ones that suffer. I've attended multiple DCYF hearings. I've seen DCYF staff accused of racial bias. I've watched an assistant attorney general tell a judge that law enforcement only supported the family because of privileges. Those arguments only take place because there's no accurate recordings of what was actually said. Judges are forced to choose between conflicting statements. That is not justice. That does not serve children well. That's guessing. The consequences fall on the child. Families can wait months to receive documentation or never receive it.
Kathy, your time is getting short. Just if
okay.
you could.
I ask school administrators use scripts when they conduct threat assessments. They're required by law. And I ask that DCYF does the same thing. And if a question comes up they can't answer, they just offer to follow up. This model prevents liability, reduces errors, and protects everyone, especially the child and the staff. Legislators, I please ask you to change laws to allow families to access recordings and take recordings when there's an abuse allegation. Innocent parents, it's absolute pure hell to have false allegations against you, but for guilty parents, it's a loophole that they can use in court. And for children, it equates to many wrong decisions. Thank you.
Thank you, Kathy. Appreciate you showing up for comment today. The next person is Jamie Williams.
Hello. Good afternoon, committee members. I'm going to start my timer because I have a lot to unpack in 3 minutes. My name is Jamie Williams. I've been a foster parent for 7 years, and I've spent most of my career as a labor and delivery nurse here in Walla Walla. I'm here today as someone who is deeply disgusted by the direction our child welfare system is headed. Healthcare providers have never had to advocate this hard to keep children safe, going as far as to refuse discharging patients with their parents. We are sending our most vulnerable children home to the most lethal environments. Over 200% increase in critical incidents is not just a statistic, it is a failure of leadership, a failure of policy, and most importantly, a failure to protect the very children that our system was created to serve. These deaths are not inevitable. They're the direct result of policy decisions that deprioritize early intervention and child safety. We are watching children fall through the cracks of a system that now places the rights of abusive or neglectful adults over the well-being of innocent children. Child welfare has completely lost its way. The so-called Keeping Families Together Act is tragically misnamed. Rather than preserving families, this law is accelerating the destruction of them. It is doing the exact opposite of what its title suggests, keeping children in unsafe environments, silencing mandated reporters, and blocking life-saving interventions. For too many children, this law is not keeping families together, it is sending them to an early grave. This is not compassion, this is not justice, and it is certainly not protection. Later today, the committee will be presenting on the gut-wrenching data regarding the critical incidents for Q1, and my fear is that all we are going to hear about is services. We've created layer upon layer of services for parents, yet the truth is many of these programs are not working. They're not keeping children safe. They're not creating lasting change. We've put all our energy into keeping families together at all costs that we have completely lost common sense, truthfully. When your house is on fire, you evacuate immediately, and then you decide what the plan is going to be. We need legislative change. We need to stop pretending that offering another service to a dangerous situation will magically make it safe. The priority must be removing the child from the threat first and then supporting the parent. That is how real reunification works. Safety first, stability next, support last. Politics aside, it is our moral obligation to protect children, and Washington State is failing. Thank you.
Thank you so much for coming to public comment today. Next, I have Christina from Keeping Kids Safe.
Yes, thank you. Can you hear me?
Yes, we can hear you.
Okay, I'm going to talk about the fatality report the Ombudsman submitted as well. They put some recommendations. I didn't think they were adequate. First, in reviewing the fatality reports for last year, which I did, we need to change HB 2027. The kids are dying because of this law. DCYF continues to blame the fentanyl crisis. Yes, there's a fentanyl crisis, but if the children were not in the home, they wouldn't be dying. We need to be active in our steps. Again, we also need to be taking CPS history into consideration. How many of these fatalities and near fatalities, there was numerous intakes, and there's years of CPS history, years. Also, we need more caseworkers, not less. We continue to ask the social workers, caseworkers, whatever you want to call them, to do more with less. In the reports, it talks about numerous times where they needed to follow up, investigate, talk to collateral contacts, get to know the family more, spend more time with the kids, all these things. Well, they don't have time. They have too high caseloads. There's too much turnover. And I missed the first half of this, but they're suffering from mental PTSD because there's constant fatalities in their office or near fatalities. How would it be to show up every day and wonder which kid has died today or almost died? It also talks about DV experts in the fatality reviews. That wasn't on the suggestions. We need to be listening to experts in their field. Mental health, we need to be listening to experts in mental health. And also talked about DCYF not having good relationships with other stakeholders and providers. Well, that's because they dismiss what they say. We need to be taking these things into consideration and changing the laws. Doesn't mean we need to take, it's important for kids to be with their families, but not at the cost of their lives. We're not helping these families. And I agree about the services. If the law doesn't make them do the services, if they refuse the services, then they close the case. And we have to wait till the next intake or one of the kids dies so we can pull the rest. How is that? How is this helpful? This is not helpful at all. Jamie is spot on. We need to take care of the crisis and then put the services in.
Got about 30 seconds left.
Please save these kids. We need to stop this. Like Travis Couture says, we may not be able to save them all, but can we at least try?
Thank you, Christina. We appreciate you coming in today to give public comment. The next person on the list is Tristan Fujita. I'm sorry if I pronounced your last name wrong.
You are fine. And I apologize. I'm on two different meetings at the same time, so I'll keep this very brief. I just wanted to reference in the next agenda item, I know you guys are discussing the Ombuds report, and I just wanted to address the discussion regarding child fatality reviews and near fatality reviews. In just looking at the brief information in the report, there is kind of a specific trend of, we spoke at length about the House Bill 1227, Keeping Families Together Act, and how that could have prevented the fatality or near fatalities. One specific comment stating there were two different times in a case that the issue here where an active safety threat was present and met the threshold for further intervention. But the staff believed, based on their experience in previous cases, the court would have denied the dependency petition. And as a result, that child passed away. We've said it before, other people have said it here. We see these recommendations, they continue to point out issues with a law that is preventing children from having safety. But it seems that while we see it, we acknowledge it, nothing is being done. We need to work on legislative change, and we're hoping that you guys can join in with that in addressing that. And just to finalize, I want to mention that it's not always just the fact that it's drug use. Like we tend to focus on fentanyl use. Very, very recently, a case in Linwood just last week or the other day, a 4-year-old child shot his mother in the arm. And while that seems like a crazy accident, there was actually fentanyl use in the home, a safety plan, apparently both parents utilizing fentanyl, nobody available to care for that child when that child accessed a loaded gun. Thankfully, shot his parent in the arm and everybody's going to be fine. But it was a 4-year-old with a 9-year-old sibling, and that could have ended completely differently. So we need to look at holistically what is going on in a home, and we need to look at how the drugs really do impact their ability to care for children, whether it's, we don't need it to just be that they are literally handing their child a gun or drugs to be a safety issue.
Thank you, Tristan. We appreciate you coming in today for public comment. The next person is Jim Theophilus.
Good morning, Madam Chair. Jim Theophilus, founder and executive director of North Star Advocates and previous founder and executive director of the Mockingbird Society in Away Home, Washington. Couple areas I want to touch on today in my time. I want to first say thank you for this really robust discussion so far. I'm so glad to hear that there's still the energy and passion to really lean in on what the Blue Ribbon Commission and what the bill was really about when we created DCYF. And I do think that there are some areas that I hope you do lean in on, and the accountability question is, that's complicated, but at least what's happening and what do we know, and then what role do you all have in holding up that mirror? Someone mentioned FFPSA. I don't hear as much about that, particularly for adolescents, as I had hoped. I think the JR to 25 crisis. And then for me, the other one that I'm still concerned about is the dissolution of the adolescent unit. I think that as I predicted, it would go away, but I don't know what replaced it, because while it was not perfect, there was some confidence that every morning there was a team of folks who woke up saying, how do we improve the lives of adolescents who are in our foster care system? And so I just really hope that that's a role that you all can play. I also will say that I think a role you can play is holding that vision, that original vision. I remember when there was talk about if we engage a family at when the child is early learning, then we're going to have some way to support that family to hopefully avoid foster care and JR involvement. So I think there's real value in that aspirational role as well. The second area I want to address quickly relates to your original presentation on opioid and JR and all of that. I want to remind folks that in 2024, the legislature passed Substitute House Bill 1929, which for the first time establishes 90-day housing for young adults exiting inpatient treatment. When we looked at the RDA data when I was at Away Home Washington and we wrote a report on it, nearly high 70%, 78%, something like that, of the young people who were homeless within 3 to 12 months coming out of a system of care, foster care, JR, or inpatient behavioral health, of those that were homeless within 3 to 12 months, 78% or thereabouts are coming out of inpatient treatment. So we've got young people who are homeless. Many of them were
30
in foster.
seconds, Jim.
Okay. I just want you to know we're starting that program. We're launching it this week. We're doing the training. There will now be, for the first time in the country, a safe place for young people to go when they come out of inpatient who do not have safe housing. And I think that's what we've got to do is when young people say yes, we've got to say yes and have services for them. Thank you.
Thank you so much, Jim. Appreciate your comments today. I've got one more, Jill May.
Hi, good afternoon. I'm Jill May. I'm the Executive Director of the Washington Association for Children and Families. And we are an organization that represents child welfare providers, including in-home services, CPAs, group care, and independent living. Oftentimes when I listen to these pretty regularly, and I don't hear any conversations about the interactions between DCYF and providers, the ones that are carrying out the contracts that are created. And I think when you're thinking about oversight and what the next iteration of the Oversight Board is, I would really like to see providers being included in those conversations and not just hearing from DCYF. I think it's a missing piece that I haven't ever heard from the Oversight Board. Thanks.
Thank you so much. So I believe that now concludes our portion for public comment. Nicholas, is there anybody else or did I get everybody?
That was it.
Okay, so everybody gets a break. We will reconvene at 11:30.
Well, thanks everyone for coming back. Rep Dent, I see your hand up.
Thank you, Senator. I just wanted to make a short comment. As we were on break, I was thinking about all the comments that we heard. And many times we hear comments from the public and we hear comments, but it doesn't go anywhere. That could be part that could tie into oversight. I mean, it's not that we need to address and look at every comment in particular and drill down into it, but it might be a suggested area of subject area that we might look into to see how it is being handled within the agency.
All right. Thanks for that input. And I know Dr. Libby also spoke to the fact that we've started a feedback loop to make sure that the information we hear and the input we get also moves forward to the agency and to the folks that it needs to go to, so that we're not counting on individuals listening in or taking action, that we are also doing our due diligence and making sure we're sharing what we're hearing. But clearly, part of the ongoing conversations we can have, as long as I think we stay at that level of thematically what's going on and what it means for the systems and the work that happens inside. And we talk about that a lot as Dr. Libby speaks about, personal individual cases are a very different scenario, but very much part and parcel to help us understand kind of the issues at hand and what's happening within. Voice makes a huge difference, as we all know. So thanks. Great thoughts. So I do want to introduce Patrick Dowd. And Patrick is the director of the Office of Family and Children's Ombuds. And he's here with us today and is going to share with us and present the 2025 Office of Family and Children's Ombuds report on child fatalities and near fatalities in Washington State. And we heard just a bit from folks who gave comment before us about concerns that individuals have, and it is a challenging and also a very critical topic and very much top of mind for so many people today and in the past and now in the future as well. So I just want to really thank you in advance for the work that you do, Patrick, and the thoughtful approaches that you take when you're looking at these kinds of issues. And also want to thank you for taking time to be here and share the information with us today. And would love you to just start off. And I think would ask you, would you prefer us to listen and ask questions at the end, or what is perhaps the best way for us to approach any questions that members might have?
Well, first of all, thank you, Chair Wilson and members of the Oversight Board. And thank you for the opportunity to present and discuss our report. My preference would be to make this as useful for each of you. And so if at any time questions come up, I think it would be best to just go ahead and raise your hand. And if I could get some assistance too, I'm not sure if everyone will be on my screen. But yeah, I think that would be best if we can just address any questions that come up as they arise.
Awesome. Co-Chair Levy and I will keep our eyes on the hands and make sure that people can ask their questions as you go. Thank you.
All right,
The
let me see
floor
if I
is
can.
yours. Yeah.
All right. Okay, so this is just a quick overview of OFGO's duties and responsibilities. And what we'll focus on today is the third statutory duty, which is reporting out on child fatalities and near fatalities and reviewing those critical incidents. Next slide. And one more. There we go. All right, so related to our work on child fatalities and near fatalities, our office receives what are called AIRS reports, or Administrative Incident Reporting System. And those include child fatalities, near fatalities. They include other critical incidents, including staff safety reports, placement exceptions, et cetera. So the purpose of this presentation, we're focusing on the child fatality and near fatalities that are documented in those AIRS reports. These are generated by the Department of Children, Youth, and Families. They represent child fatalities and near fatalities that the department becomes aware of. And generally, those are because the department receives a CPS intake report, or if it's a family that's already engaged with the department, they learn of a critical incident involving a child. It's important to note that the information in our report and that we'll be discussing today does not represent every child fatality or near fatality that occurs in Washington State, but rather that's filtered down to those critical incidents that the department becomes aware of. So there are other sources of information, for example, that our office does not have access to. Those might be records in local health departments that might also document child fatalities and near fatalities. So again, this information represents a subsection of all the child fatalities and near fatalities that occur in Washington State. We review these critical incidents for a number of reasons. One is to determine, are there other children in the home? Are there safety issues that the department needs to address? So we're looking at it from the view of, child safety and risks that are current in the home and whether or not those are being adequately addressed by the department. Then we're also looking at, do the facts and circumstances of this critical incident, does it meet the legal qualifications or criteria for the department to conduct either an executive child fatality review or a child near fatality review? And quickly, that criteria is one, that the fatality or near fatality is attributed to child abuse or neglect. And secondly, that the family was involved in receiving services from the Department of Children, Youth, and Families within the preceding 12 months. And if it's unclear, for example, if the fatality is attributed to abuse or neglect, then our office has a discussion with the department to make a final determination of whether or not a review should occur. And then we're also looking at those cases to determine whether or not the department's action or conduct would warrant further investigation by our office. So we have the ability to initiate investigations on our own. And there are situations where in the course of reviewing an AIRS report of a critical incident, we will see something that will cause us to say, let's take a deeper dive in this particular case and look at, were health and safety visits occurring prior to this critical incident, or was the department providing court-ordered services, for example. And then finally, we're reviewing them to identify any systemic child welfare issues. And we'll discuss specifically those kind of systemic issues, later in this presentation. Next slide. So this slide describes let's talk about the blue line first. This is the number of AIRS reports that our office receives each year that are attributed or regardless of the cause. So that's the total number. So in 2024, there were 78 child fatality AIRS reports that our office received and reviewed. One less than in 2023. So basically, kind of that number has stayed the same. Again, this includes not just fatalities that may have been related to child abuse or neglect, but also includes fatalities that were attributed to a medical condition, for example, of the child, or had nothing to do with allegations of child maltreatment. So of those, that total number of 78, the green line at the bottom describes the number of child fatalities that received a executive child fatality review. And again, that means that the fatality was attributed to child abuse or neglect, and the department had been involved with the family. The family had been receiving services in the preceding 12 months. The orange line and so the blue line and the green line, those numbers should be, if not the same, very consistent with any data that DCYF presents or has. The orange line is that data is something that is created by OFCO. And our interest is like when you just look at the number of child fatalities and then drop to the green line, the ones that qualified for review, it's leaving out other child fatalities that in fact were attributed to abuse or neglect, but the family had not been involved with the department at all or in the preceding 12 months. So they're not captured in the number of cases that received an executive review. Additionally, in reviewing these cases, sometimes the cause of the child's fatality is not clearly attributed to abuse or neglect, but we identified that there were child maltreatment concerns that we also want to capture in that data. So that could be an infant and the fatality is attributed to sudden unexpected infant death, and which is kind of an undefined cause. But we might, in our review, find that, well, the parents had a history of substance use disorder. Maybe there was drug paraphernalia in the home at the time of the fatality. There might not be a clear nexus between those circumstances and the fatality itself, but there are child maltreatment concerns that we think are important to try to capture and describe. So that's what that orange line represents, is so in comparing it from 2023 to 2024, we see that the number of child fatalities that we examined and thought were related to child maltreatment decreased from 49 to 38. And again, I want to emphasize that 38 includes child fatalities that were attributed to abuse or neglect, that did receive a review, as well as those that did not receive a review because the department had not been involved within the preceding 12 months. And in addition, it includes those other cases where we cannot say definitively that the fatality was related to abuse or neglect, but we identified factors of child maltreatment that may have contributed to the critical incident. Next slide. Similarly, this is the same information, but rather than describing child fatalities, it describes child near fatality cases. And again, the overall number of child near fatalities, regardless of the cause of the near fatality, decreased from 70 in 2023 to 62 in 2024. The green line, the number of those near fatalities that were attributed to child maltreatment and the family was involved with the department in the preceding 12 months and received a review, the green line, those also slightly decreased from 31 to 29 this past year. And then again, the orange line, the one that is the information that OFCO collects, is a little broader to try to capture the cases that don't qualify for a review, and also includes situations where child maltreatment may have been a contributing factor to the critical incident. Those declined as well from 53 to 44. Next slide. So this year, we also included in our appendix to our report data for the first quarter of 2025. And this is something we had not done in the past, but we wanted to provide the most updated information that we had. And we also thought it was worth note that there was an increase in the first quarter of 2025, both of all of critical incidents, fatality and near fatalities that we received. That went up to 47 in that first quarter of 2025 from the previous numbers in 2024. That was an increase. And then we also noted an increase in the subcategories of like how many of these cases involved accidental ingestion and overdose, how many involved fentanyl and opioids, how many involved accidental ingestion by a child between the ages of 0 and 3. How many of these critical incidents in that first quarter of 2025 received an executive review, either a fatality or near fatality review? And in those categories, we also saw an increase. So we wanted to, when we looked at the previous two slides, we saw a slight decrease in the number of child fatalities and the number of child near fatalities. And we didn't want to, leave a reader with the misimpression that we know things are getting better and things have topped out and are actually starting to decline, when in fact we had preliminary information from the first quarter of 2025 that might paint a very different picture as we move forward into 2025. Just earlier this week, I looked at our numbers for the second quarter of 2025. And that's not included in this slide, but again, it showed 45 errors reports regarding child fatalities and near fatalities compared to 47 in the first quarter. There were 6 cases involving accidental ingestion of fentanyl by children ages 0 to 3, which compares to 14 cases in the first quarter of 2025. And as far as cases that qualify for a review or received a review, in the second quarter, 9 cases have either already received a review or are now scheduled for a review, meaning, yes, the critical incident is attributed to abuse or neglect, and the family was involved with the department in the preceding 12 months. And then there are another 12 cases where the department is waiting for additional information, which is not unusual. Very often at the time of the critical incident, there's not enough information to determine what the cause of the near fatality or fatality was, if it was directly attributed to child maltreatment or not. So we wanted also to include some information that might paint a picture of where things are heading in 2025. Obviously, we don't have anything definitive, but we thought it was important to kind of report on the information that we have at this time. Next slide, please. So this describes, again, now we're talking about in these slides, it's not just the cases that qualified for a review, it's that orange line number of all of the fatalities that OFCO identified as either clearly attributed to abuse or neglect, or there was child maltreatment concerns that may have contributed to the fatality. And in those cases, what we found was that, again, 36%, almost 37%, it was clear neglect was the cause of the fatality. About 18%, it was clear physical abuse. And in about 45%, those were the cases that OFCO identified as there were contributing factors of child maltreatment that may have played a role in the fatality. Next slide.
Patrick, do you have an example of what might fall under child maltreatment?
Yes, child maltreatment concern. Again, I think that a good example of that was one of the, it's an infant. It's the official kind of medical examiner determination is sudden, unexpected infant death. So it's not attributed to caused by physical abuse or neglect, so it doesn't fall into that category. But yet in the errors report, it might describe other circumstances that either substance use disorder history by the parents or caregivers, drug paraphernalia being in the home, maybe an unsafe sleep environment that would also contribute to possible neglect. So those are the cases that we would try to call out and say, we cannot pinpoint and say this was definitively attributed to physical abuse or neglect, but there's enough concerns here that we want to kind of capture that. Something that I should have mentioned, when we talk about the cases that are under the category of clear physical abuse or clear neglect, that is not a determination that our office makes. We are relying on, it might be a law enforcement finding. It might be a CPS investigation that concludes the caregiver or parent, there's an administrative finding of abuse or neglect by the caregiver or parent. And so that's the determination that's made that when something is clear physical abuse or neglect. So this is the same information for near fatalities, I'm not sure what to read in this, but the number of near fatalities where we are saying, you know what, there's enough other factors in this incident that may have contributed to it and will classify it as child maltreatment concerns, about half as many in near fatalities as in the fatality cases. And clear neglect is much higher in the near fatalities, and the physical abuse is lower than in the child fatality cases. Next slide. So these next few slides will kind of describe the child's age. And I think this is very important. Also, when considering what are the best strategies for protecting children and strengthening families, to kind of identify like where do we see the most of the harm, if you will, or the these critical incidents occurring. And in regard to child fatalities, you know, what we see is that the vast majority are 0 to 12 months old. So we're talking about infants. And then when you expand that to looking at the 0 to 3-year-old and including the toddler population, that makes up 31 of 38 child fatalities that were either directly caused by child maltreatment or there was child maltreatment concerns. And next slide. And we see kind of a similar pattern with near fatalities. The number of near fatalities is actually higher with that kind of 1 to 3 population than the 0 to 12 months old. Again, this is just for data for 2024. I'd have to go back and look and see if this is consistent in past years to see if that's an ongoing trend or not. But again, for me, the main takeaway again is when we're looking at that 0 to 3-year-old population of children, both in fatalities and near fatalities that are related to abuse and neglect, that's the majority of these critical incidents. Next slide. So these next 2 slides kind of look at, okay, so of the cases where the department was involved with the family in the preceding 12 months, kind of what does that look like? And so as far as the child fatalities, what we see is that 42% of them, the case was open at the time of the child fatality. And when we drill down a little bit more of that, like, well, what kind of open what kind of open DCYF case was that? We found that there were 9 that were open for a CPS investigation. There were 4 that were open for child and family welfare services. 2 were open for family voluntary services. And there was 1 that was open for a family assessment response. And another 30%, the case was closed in the last 12 months. And then there was another kind of 18% that were the only contact with the department was a CPS report that was closed as information only, and there was no direct involvement with the department or services to the family. And next slide. So same information for near fatalities. 34% were open at the time of the near fatality. The table needs to be corrected. It says open at the time of death, and that should be near fatality. And of those ones that were open, there were 5 CPS investigations, 4 that were open for child and family welfare services, 5 were open for family assessment response, and 3 that were open for family voluntary services. Half of the near fatalities were closed cases that had been closed within the last 12 months. The 2%, that light blue line, you ask, well, what are those? And what we found is those are cases that were open for tribal services. So it was, and I think that represents 1 case. And next slide. All right, so now I want to talk about what I think is a focus of a lot of attention, rightfully so, and that is in this larger population of critical incidents of child fatalities and near fatalities. Those are that are directly related to accidental ingestion and overdoses, and that's what the kind of next few slides will address. Let's see. Now, the older children, the ages 12 to 20, it says and ages of 11 to 22, accidental overdose. Those are generally intentional ingestion and then accidental overdose. The last line, the intentional overdoses, those are ones that are attributed to a suicide or a suicide attempt. The top line is accidental ingestion of drugs, children ages 0 to 11. And these are the ones where usually it's a younger child accidentally picks up some foil and puts it in their mouth or a tablet and ingests it, and then that leads to the critical incident. Again, in looking at the numbers compared to 2023, we've seen a decrease in accidental ingestion and overdoses. This would be both fatalities and near fatalities involving children ages 0 to 11. Decrease from 45 to 38. A slight increase of accidental overdose by children ages 11 to 22. Next slide.
Patrick, can I ask a question?
Sure.
And that is there any differentiation between legal fentanyl, like fentanyl patches and things that would be a prescribed medication, and those that are not prescribed that way, as we think about both near fatalities and fatalities? I think as we lump those things together, and I think not every response is illegal, necessary, and illegally received drug, if that makes any sense. Is there any?
That's a great point. So this would include prescription medication, that it would include, and which would also include medically assisted treatment, that a parent might have, that a child accidentally kind of has access to. And our data, we haven't been able, or we haven't drilled down to distinguish kind of all of that.
Okay,
but that's a great point. So this goes into more detail about accidental ingestion and overdose by age of the child. And again, this is not limited to fentanyl. It would include any kind of legal or illegal substance. And, again, the clearly the most vulnerable children, no surprise, are the youngest. And, so as far as like 0 and 1 year olds accidentally ingesting and suffering an overdose, last year the numbers were 17 and 15, and then it drops to 4 and 2 for children ages 2 or 3 years old, and to 0 for children 4 to 10. So again, what jumps out at me is how should this information help structure interventions and services and the way we engage families, either through the community pathway or through the Department of Children, Youth, and Families. And next slide. So this, now we're kind of looking at the drilling down from the, ingestion overdose cases. Could you go back one, Nicholas? From all types of drugs to specifically fentanyl. As we all know, the fentanyl crisis has had a huge impact at every corner of our community in many, many different ways. And this is just capturing one piece of that in regard to critical incidents involving children. Again, when compared to 2023, there was a decrease in both fatalities and near fatalities, going from 15 fatalities in 2023 to 12 in 2024, and 42 in 2023 as far as near fatalities to 36 in 2024. Again, I referenced kind of my previous comments about the first quarter of 2025 and the preliminary numbers that our office has gathered in the second quarter of 2025. So I think it's still unclear what this will look like at the end of December as we have more information. Next slide. So now we want to talk about kind of our recommendations. And in kind of formulating our recommendations, we went through each of the executive child fatality reviews that were done this past year, as well as the near fatality reviews. And, I mentioned at the very beginning that our office, part of our duties include reviewing child fatalities and near fatalities. And that includes that we participate in each of the executive child fatality reviews that are facilitated by the department, as well as the near fatality reviews. And when the department facilitates these reviews, they pull together a team of both kind of internal team members of professionals within DCYF that have not had prior involvement with that particular case. And they're from a different office or even a different region, but they have expertise. They might be a quality practice specialist, et cetera, to participate in the review. And then also included in those review teams are external team members. And depending on the circumstances of a particular critical incident, if it was one that involved partnering with law enforcement investigation, they might have a law enforcement detective. If it involved a family with a history of domestic violence, it would include a community member with expertise in domestic violence assessment and services. If it involved substance use disorder, it would involve a community member with expertise in that field as well. And our office participates in each of those reviews. So we have the insight of both participating in them in real time, if you will, and then also in compiling our report, we go back and review all of those and look for common themes and to kind of base our recommendations. So that was kind of our process. And the recommendations that really jumped out to us were one, expanding treatment resources, both outpatient and inpatient, for substance use disorder treatment. And that there was a pattern of, in these cases, of a family's initial or recent involvement, whether that was CPS intake screening, intake reports that would document some history of substance use disorder. That may or may not be the direct cause of the critical incident, but that was a common theme that we saw. And we also saw situations where the department would engage, and for a variety of reasons, the parent not being connected with a treatment program or being connected but not completing treatment. And so, part of our recommendation is to ensure that there are adequate treatment resources for families that are experiencing substance use disorder, particularly those with young children, infants, and toddlers. As we saw in previous slides, those are the children that are most at risk of a critical incident, and in specific, those that are related to accidental ingestion and overdoses. We also know that substance use disorder treatment resources are not widely available everywhere throughout our state, particularly inpatient treatment programs for parenting and pregnant women that would allow the parent to receive inpatient treatment with her child in the facility, and that these are really needed services if we are going to actually prevent these critical incidents. Earlier today, there was a presentation that included the plan of safe care and the community pathway and the portal that can that could engage families without going through the CPS process that obviously can be problematic in successfully engaging some families. So these resources need to be available both through the community pathway as well as for those families that are directly involved with the Department of Children, Youth, and Families through a more formal family assessment response or CPS investigation. We also noted in our review that there was very often in the discussion, team members would note that there was inadequate efforts made to engage fathers. And there was a kind of a variety of reasons why that might occur. Sometimes when CPS receives that first report, the whereabouts of the father might not even be known. Or there might be other barriers. There might be a father that is kind of unwilling to engage with the department. And we've discussed, topics like making greater efforts to use different interviewing techniques like motivational interviewing to engage fathers, et cetera. And this is important for a variety of reasons. One, primarily, it's the father's right, obviously, to be included in that discussion when the department is involved with the family. But also just to assess the father as a resource for supporting the family and engaging the father, determining if there are services that the father needs and not having a singular focus on the mother, which can occur in some cases. Additionally, very often the department is looking at what family resources are available. And if we're not engaging the father, we're eliminating potentially 50% of those other relatives that might be available to help support the family. And this is not something new. I know the department has made other efforts in the past to increase efforts and initiatives to engage fathers, but that's something that we noted came up frequently in these both fatality and near fatality reviews. And then our last recommendation is to explore the use of in-home dependencies. And the traditional model, if you will, has been that when the department decides it needs to seek court supervision and structure, it is at a point where the department has decided that it needs to go to court and obtain a order to pick up the child, to remove the child from the parent's care. And that is really the first step in the process of obtaining court oversight through a dependency. There are many, I think, advantages to the dependency process. One, unlike a CPS investigation that has distinct timelines, CPS has up to 90 days to complete an investigation. And then they pretty much have to, unless there's an exception, they need to close their investigation. And our office is frequently on their tail, calling them saying, this CPS investigation has been open for over 90 days. What's the holdup? So they recognize the need that they have a limited period of time to complete their investigation, to engage the family. They do have an option of referring the case to Family Voluntary Services, but that's just kind of one kind of option. A dependency, or the court structure, on the other hand, provides a longer period of time to engage the family. It provides court oversight, not just of the parents, and I think this is a point that sometimes parents don't realize, but also oversight of the department. So if there is a service plan that requires the department to provide concrete goods, referrals for services, etc., and if those referrals are not being made in a timely manner, if those services are not occurring, the parents have that right to go back to court and say, hey, the department is not doing their job. And so the court is there to hold all parties, accountable. Unfortunately, what we see again is the reliance that everything is predicated on the child being removed from the home, which is not really how the state law is structured, but in reality, that's how it works. So I'm not saying this is a solution. I think it is an idea or a concept that is worth exploring. And I think it would take a significant shift in perspectives by pretty much everyone that's involved in the traditional dependency process, the judicial officers, the attorney generals, assistant attorney generals representing the department, the caseworkers, and certainly the parents' attorneys representing parents in these proceedings, that in some cases would kind of prompt them to see the potential benefits of a in-home dependency rather than not receiving any services from the department and risking future involvement with the department, which may very well involve the immediate removal of the child. So those were our recommendations in our report. Looks like I finished with about 10 minutes or to spare, I think. So happy to open it up for questions.
I see Ruth.
Thank you, Patrick, very much. It's always very illuminating to read your reports. And, we earlier heard public testimony concerning whether children are safe or not, and how the new law has changed the way that the courts and the department treat child safety. And I'm just wondering if you considered making a recommendation about change in the law, if you think that is something the legislature should be looking at.
That is something that our office considered. We did not make that recommendation, and this is why. We did not see kind of, again, in reviewing the fatalities and near fatalities that received a formal review, as well as those other cases that didn't qualify that we review internally. we did not find in many cases a certain point where if only 1227 had not been enacted, then the department would have filed. There were a couple cases where that was discussed and workers debated, in the review. They discussed, yeah, there was this point where we thought maybe we should seek removal, and they even talked to their AG, and they made a decision not to. But that was, I think, the exception rather than a common theme that we found in these cases. I think what is much more common is a situation where there was an open family assessment response or CPS investigation. And in the course of that involvement with the department was nowhere near a point of having a factual basis to seek removal under 1227 or before 1227 was enacted. That wasn't even a consideration. And the case is closed. And then within the next 6, 7, 8 months, there's a critical incident. That is the dynamic that is more prevalent. And the other kind of factor I think it's important to note is the impact of Senate Bill 6109 that was passed after 1227 that I think really kind of recognizes the legislature recognized, oh, wait a minute, maybe we need to do something in response to the fentanyl crisis, and specifically to help guide the department and professionals and judicial officers in these cases, and addressing the lethality of high potency synthetic opioids in these cases. And as a result, within the child welfare field, we have seen quality trainings by the Office of Administration of the Courts on 6109, on the impact of fentanyl and synthetic opioids, and how to balance that both the potential harm of removal with the priority to ensure the safety of the child in consideration of the impact of fentanyl. The other thing that I've seen is, and this is just in our daily work of responding to individual complaints and investigating them, I've seen a shift in practice within the department where when they do go to court and seek a pickup order and remove a child, that the affidavit, the dependency petition, laying out the basis for why these circumstances constitute imminent risk of physical harm, which is the standard under 1227, is met. And that changes that they're much more detailed in articulating the connection and describing the parent's substance use disorder, their current circumstances in the home, conditions of the home, the vulnerability of the child, and how those circumstances directly impact the parent's ability to safely meet all of the child's basic needs, and why these circumstances constitute, in this case, imminent risk of physical harm. So they're not just going to a court and saying, mom and dad have unaddressed substance use disorder problems. We received an intake here and we want to pick up the child. That is not sufficient. And the department, again, I think is doing a much more detailed job of how they craft their information and present that information to the court when they are seeking removal to meet that standard of imminent risk of harm.
I want to thank you so much. And I am going to step in just because We've got one more set of information before we end our time together. And Patrick, always just deepest appreciation for the work you do and the support for the understanding about the why and the complexity of what we're talking about. It is so multi-layered, multifaceted. And again, ultimately, the care of our youngest is ultimately our goal, as well as supporting families early and often, I think is critically important. So thank you so much. If we've got further questions, I know we can follow up. And if any members have questions as well, we'll make sure that we get them to you or you to them.
Sounds good.
So
You know where to
thank you
find me.
so much. And with that, we are going to next hear from Dr. Vicky Ibarra, who is Assistant Secretary of Partnership Prevention and Services, and Doreen Perez, who is the Deputy Secretary for Child Welfare. And I want to thank you all for kind of being our wind up today, if you will. And they are both going to provide us a briefing and response to the 2025 increase in critical incidents that we saw and we heard about that occurred in Q1. And so just going to pass that on to them. And again, the question I would have is, would you like to present and then provide opportunity for questions, or would you like folks to ask questions along the way?
Thank you so much, Co-Chair Senator Wilson. We would love to get questions as we go along. We do not have very many slides for you today, and so we'd like to be informal if we can and answer questions as we go along. Thanks so much for having us today. As Senator Wilson noted, I'm Vicky Ibarra. I'm Assistant Secretary for Partnership Prevention and Services, and I'll ask my colleague, Doreen, to introduce herself.
Good afternoon. I'm Doreen Perez. I'm the Deputy Assistant Secretary for Child Welfare with DCYF.
Thanks, Doreen. So we have, as I said, just a few slides for you today. I think having heard Patrick's presentation is excellent background, and I think we should be able to provide some additional information as well as some additional details that might be helpful in answering your questions. Just to start out, as Patrick noted, there is a bit of difference between the data that OFCO reports on and the DCYF reports on. The primary difference being our reports are limited to those child fatalities, near fatalities that are prescribed by our CW that we are required to review. We're both related to maltreatment and have had child welfare involvement in the last 12 months. So as Patrick noted, our data will be a subset of the larger errors reports that Patrick is seeing and the OFCO office is analyzing. We believe both of these are a subset of the larger group of child fatalities and near fatalities that happen in the state of Washington. So just to start off, these are our up-to-date numbers. You see a trend here from 2020 to 2024. Fatalities and near fatalities in the same slide. The actual numbers for each are in the table on the right. And then our Q1 2025 data. The orange line indicates those that were fentanyl related, both fatalities and near fatalities. Thankfully, most of the fentanyl related critical incidents that we are seeing this year and most from last year are near fatalities, not fatalities. And we attribute the growth in the percentage that are near fatalities to the increase in harm reduction that has happened throughout the state over the last few years. We did see, as has been noted, a concerning increase in Q1 of 2025 when the numbers were all counted. And some had been taken off the list because of medical examiner determination. We know now that there were 22 DCYF reviewable critical incidents in Q1 of this year versus only 9 in Q1 of last year. 2/3 or over 2/3 of the Q1 critical incidents were opioid related, and about 1/3 were non-opioid related. And then, as was noted, a significant portion occur among children birth to 3. 17 of the total in Q1 of this year versus 6 in the Q1 of last year. And then of the 13 of the 17, I'm sorry, yes, 13 of the 17, 13 of these 17 for children birth to 3 were related to opioid in Q1 2025. So you see the comparison here in the detail between 2024 and 2025. This was alarming to us. This was very concerning. In digging down in the data, we did identify that there were some geographic hotspots in Q1 that hadn't shown up in previous years. Spokane had quite a spike in the first quarter of 2025. We haven't finished analyzing the data for Q2 yet. As I noted, sometimes these numbers get smaller because medical examiners make determinations, and that sometimes takes a bit of time. But it does appear as though the numbers are moving in the direction of double instead of triple, which I suppose is good news, although certainly on track to set a record this year. We, as I said, continue to dig into the data and analyze it, but at this point, we don't believe there's any one reason for the increase. Our initial analysis points to 4 main drivers. The fentanyl epidemic has been mentioned, increased parental stress, particularly economic stress, as many of the COVID era economic supports have gone away, and the economy is hitting particularly high need, low income families, especially hard. We are seeing an increase in families in our child welfare system who have high needs, and I'll show you some data on that. So we think there is an increasing pool of families with high needs that are circulating at the front end of our child welfare system without placement, and for whom their needs may not be being met. And then just the complexity of cases and the systems involved, with a number of major legislative changes in the last few years. These systems, all of the systems involved, are trying to respond, and also we believe we're seeing an increased complexity of cases, particularly with all of the other factors happening. This is the slide I like to use to demonstrate how we are seeing an increase in the number and percentage of families at the front end, so without placement at the CPS side of our child welfare system, that are churning or re-referred and re-screened in within 180 days, so within 6 months. And this varies by the level of need of families. We use the structured decision-making tool to make assessments at the front end, and those we can see SDM level of low, moderate, high, and high. And it's those moderate, high, and high need families that are where we've seen especially seen the growth in re-referral and re-screen in. This is not a brand new phenomenon. This does not start with 1227. It started before. We see here in between 2020 and 2021, we see the first substantial rise, but it has continued. And critical incidents come largely from this group of families who are not placed, but where children are not placed in out-of-home care, who continue to come back into the system. And this is an indicator to us that their needs are not being met after their case is closed. Their needs aren't being met in the community, and so they're being re-referred. I know there is often a lot of focus on, and Mary, I see your hand. Let me just finish this last bit, and I'll take your question. We often get a lot of focus, and we're happy to answer any questions we can related to the specific circumstances of the children in critical incidents. And we, as you know, we publish the fatality reviews. We want to be transparent with what we know about the circumstances of those families, because we want the number to go down too. But in the end, even with the increase we've seen, this is a relatively small portion of the families we serve in our child welfare system. And at the end of the day, the needs and risk factors for those children and those families are not that much different. They're not really statistically any different than this group of high need families turning at the front end of our system. They are very high need. When they're with us, there are not enough safety concerns to rise to the level of removal, but those are high risk environments, and it doesn't take much for a circumstantial change to change something in the family so that the child is no longer safe. Thanks. Mary, you had a question.
Yeah, I'm just curious if you could say more about, like, when we say moderate to high needs, like what kind of needs are we talking about with these families, like housing, treatment, economic instability? I assume probably like all of those things. I'm just wondering, like, more if you have more to say kind of about what those needs typically look like for families.
Yeah, thanks. That's a great question. We have done some targeted case reviews and some data analysis trying to look at the needs of these families. We see some commonality, so high substance use needs, so high treatment needs. We also see high mental health needs. And in some cases, for those families who have children that aren't infants, so there's sort of a category who have children who are infants, and we know the stories about those families and their need for treatment. But there are another group of families in this category who don't have very young children. We see high child mental health needs. We also see some children with special healthcare needs subcategories here. So think about families who may have a lot of needs, a lot of instability, and also have a child with special needs. Often those families are not able to keep up on the needs of that child, the medical needs of that child, and that will cause them to enter the child welfare system. So we see a variety of needs. Thanks for the question. So what is it that we are doing currently within existing resources? Currently within existing resources, we are trying to address what we can. And I'm going to turn it over at this point to my colleague, Doreen Perez.
Thank you, Vicki. As Vicki had talked about, we have been diving into this data for some time now and trying to come up with, based on the information we find, ways to be really intentional about how we're targeting this. And so one of the ways we have identified that is one of our 6 regions had begun to do safe child consults on every case that involved opioids and a child under the age of 3 prior to case closure, to ensure that enough information gathering had happened, that they had done an accurate assessment of safety, excuse me, prior to closing the case. And we saw success in that. And so we expanded that across the state. So about March of this year, the directive was given to each of the regions that they implement at a minimum that same process. Some of the regions determined to do that for any child under the age of 5, and some determined to do it on all cases prior to closure, regardless of opioid involvement or not. And so basically, as of the end of April, every region is participating in this process now. Safe child consults have always been available, but doing it at this point in time is where we're very intentional in targeting that. We are currently in the process of mining the expertise of our frontline staff. After looking at the data and trying to figure out where we could find some commonalities, we realized we really needed to get into the regions, talk to our staff, survey them, find out in their areas what community services they may have that we're not aware of that is helping this, what community organizations may be available and are tackling this that is helping them, because they've got a place to send families to that is outside of our involvement and would be available as a safety net as our case closes, and then they have available services in the community. So that is, we just surveyed our staff, and in September, Natalie Green, the Assistant Secretary for Child Welfare, and I will be doing round tables at each of the regions. So we'll be doing that 2 sites of each of the regions through the month of September. Then we're going to be synthesizing all that information to determine what can we gather from that would be helpful moving forward. Vicky also talked about the geographic hotspots and gave an example of identifying that in Spokane in the first quarter of this year. And so as a result of that, her team and our team did a very targeted approach to highlighting the services that were available for our staff, but also for the providers, ensuring that the providers, and that's an approach that I think is unique and different from what we've done in the past, but ensuring that everyone's aware of what's available, providing information to them, providing opportunities for the providers that are in the community to come and talk to our staff about their services and to troubleshoot situations. And then we also have been increasing our caseworker trainings for neglect and medically complex cases. There was a subset of children where we were seeing that their medical needs were not being quite as well identified by the provider community. And so through Vicky's team, they've been reaching out to the pediatric medical professionals across the state and having that conversation with them and helping to talk about whenever they have any indication, they really need to be letting us know so that we can determine if there is a need to intervene on families and help ensure that children who may be medically neglected get interventions sooner than to the point of it becoming a critical incident. Next slide. What is needed? We have identified so far, truly, this is about having the resources in the community. So essentially having an aftercare program after CPS is involved, that families have access to a robust system of care that is going to help them be successful after we're out. And that includes home visiting, that includes parent-child assistance program, that includes public health nurse interventions. I'm sorry, I don't know if you guys heard that. Anyways, I apologize for that. Partnering with family resource centers, social safety net for families with high needs, and this includes housing and basic needs. We're very concerned about this in particular with the direction that we're seeing at the federal level. And this is something that we had identified during the pandemic, that once these additional resources, the child tax credits that families were getting immediately, the pandemic dollars that people were getting, and the moratorium on evictions. Once those all were lifted, we started to see an increase because that increases the pressures on families. Many of these families are able to manage and just stay on top of the things, the pressures and the stresses that they're experiencing. But you introduce a new person into the household, they get a new partner, somebody loses a job, they lose transportation, they lose their housing, and that is all it takes is to send them over that edge, and then they are in a situation where a critical incident is likely to occur because they don't have that safety net, and their critical basic needs are not being met any longer. Additionally, we identify the mental and behavioral health services, same-day substance use treatment, and peer navigation. This is not easily available across the state. It is largely available in the urban areas, but not as readily available in the smaller and rural areas. As well as Ofco and Patrick had identified, pregnant and parenting women beds. These have been shrinking over time, and in some areas we don't have access to these at all. And we definitely have an increased need for them. And lastly, consistency in application of the law. There was, Patrick talked about how our caseworkers, and thank you, Patrick, for giving us that recognition that you've seen an improvement in our dependency petitions. We put a lot of effort into training our staff since 1227 and since 6109 on how to articulate this to the courts. But we're still having the struggle because it's not just about articulating the imminent risk of physical harm, but how you balance that against the harm of removal. And when we go into court, and there's been, shall we say, there's different training levels that have happened with some of our court partners where there's emphasis in different places. And whereas the department emphasized a balance between these two, we've seen some of our court partners had a training approach that emphasize a different level and is placing more emphasis perhaps in different areas. And so just having also a consistency in application of the law, we see some jurisdictions that have taken approaches to how they make these decisions very differently than other jurisdictions, the majority of the jurisdictions across the state. I believe that's our last slide, Vicki, or is there one more?
Yes,
That's our last slide. So open to questions.
Well, I will just say, as the sponsor of 6109, I truly appreciate the work that's been done, because we did hear two things. One is courts needed to have training, judges needed to have training. But the other thing was that our individuals who work within DCYF needed to have support as well to make sure the information they were bringing to the courts were what the courts were going to be asking for, and that they felt like they were coming in ready and able to respond to what was being asked of them. So to hear those things moving forward brings me great joy. I'll just say that. And I said it earlier, and I'm still concerned when we look at our fiscal situation. None of 6109 of the resources we were able to implement because of our budget issues. And as we move forward, we're only going to be able to help folks when we've got money to be able to do that and put those dollars in these places. And so I, again, just have a focus on that myself as we think about what's best for kids and what's best for families and how do you balance that. So I just want to really thank you for the presentation. And I see we have two hands, so let's start with Katie and then we'll move to Dr. Levy.
Thank you so much, Senator Wilson. Doreen, I just wanted to kind of ask you to restate a clarification for me. So it sounds like the critical incidents, when you drill down into the data, are not happening. It sounds like it's a family that is struggling, that the department is becoming aware of because there are some issues arising, but the issues don't rise to the level of removal. And that family is kind of high risk, floating along, and then crisis happens. And you named a bunch of crises. And that's when we kind of see the critical incidences occurring, is once this high risk family has tipped into crisis. Is that a correct understanding?
I am going to speak to that, and I'm also going to ask Vicki to speak to this as well. And yes, that's basically so far what the analysis is showing us is that, and Vicki had that chart where you saw that high risk to high risk, moderately high to high risk families is where the majority of these critical incidents. At the time we close cases, it's determined that the child is safe. There is no active safety threats that have not been able to be mitigated in the home. And we cannot continue to be involved in a family's life if they're not willing to participate in services. So even though there may not be an active safety threat or a safety plan that we are having to monitor, if families want services, we can and will provide that to them. And we will do that in our voluntary services teams. But if they don't, and we do not have legal sufficiency to bring this case into court, as Patrick also highlighted, we have no legal avenue to do that.
And
Vicki,
I would just,
anything you want to add?
Yeah, I would just add that I would say it's that is the case for the majority of the critical incidents we're seeing. We are seeing some critical incidents that occur in children that we have filed on, but that's a minority of the cases.
Thank you so much. I appreciate it.
Excuse me, Diane.
Well, I've sat through several of these presentations recently, and I have to say I have this mental image of a tip of an iceberg, which is that we're talking about fatalities and near fatalities, which is like the very tip of the iceberg of what we see in morbidities related to child abuse, neglect, maltreatment. And I know what you're saying is that legally you can't necessarily step in, but it just, I guess in my mind, I just think about things like FFPSA and that the need to really work on prevention, to look at the big spectrum of what certainly I see in my office as a developmental pediatrician further down the line of things that are secondary to maltreatment, exposures in alcohol and drug in utero. All of these things kind of compound, and this just feels, I just needed to say that I feel like we're just looking at the tip of the iceberg of what these families and children are actually experiencing.
Thanks, Diane. We would agree that there is substantial need for prevention, especially as families in communities across the state experience increased economic stress, and will experience more as we see Medicaid reduced and SNAP reduced and other important social services. We would agree.
We've kind of chatted before. It's all discretionary. Everything we're talking about today. Discretionary income when we look at our state budget. And so we've got to figure out how it is that all individuals are deserved, if you will, but it takes money to provide those services. It's one thing to write legislation and to require something. It's another thing to as legislators and as the legislature and as the people of the state to then say, we also need to now invest in and put those monies there, because we know return on investment also is going to be greater the earlier that we can touch families and touch young children. So really very difficult conversations, especially when we think about our youngest again, just really tough. And then given the challenges we know coming not only inside our state, but right now federally, and the challenges, as you said, Vicki, with SNAP, Medicaid, just our safety nets as a whole, it is not necessarily going to be better before it's worse. And so we really have to think about what that looks like and how we leverage resources and support. So we are at 12:53. We have a couple minutes if anybody has any other questions. Okay, I just gave you my teacher 3001, 3002, 3003, 3-second wait time. So with that, I just want to really, unless anyone else has anything to say for the good of the order, I'm also going to give my co-chair a chance to say something because I don't want to be the only one. But I just want to say today, we heard a lot of things, and I want to really appreciate people's time and their attention. And really, hopefully, had a highlight of all the data-driven work that's happening, and hopefully we can be helpful in making data decisions and figure out what our role is as the Oversight Board to support the work of the agency, but also the outcomes for kids and families that the agency is doing. And also, just want to really appreciate all the folks from both DCYF and from OVCO and who spent time with us today to really give us a nice landscape, unfortunately, I guess, of what's happening. And with that, I'm going to pass it over to Dr. Levy one last time and remind you that our next meeting is Monday, August 18th.
Well, I won't keep you too long. I'm just going to say that in one of the presentations, I think it was Doreen, you had a list of things that you wanted to see happen. And you didn't mention that they all have a price tag and that some of those things were in the works before the funding got withdrawn. So I just wanted to mention that I think it's important that we continue to advocate for those resources, for that public health nurse initiative that you guys had put together. That sounded great. It was a piloting program. It was all set to go. So we need to look at, as you said, resourcing so that you can have the resources to get some of those effective programs out and working. Anyway, I don't know if that's my hat as a pediatrician rather than my co-chair hat, but I just had to say that at the end.
Yes.
So, all right. Thank you all for a long, very thoughtful meeting, and we will see you in August.
Awesome. Thanks all.
Bye.
Bye.
Thanks, everyone. Bye-bye.